Vanakkam, LVK.
sir.
Good evening. Good
Yeah,
evening.
Vanakkam Pare. Yeah.
Vanakkam.
Good evening, LVK.
LVK.
Vanakkam.
Vanakkam.
Good evening, LVK.
Good one. Yeah, Vanakkam. நல்லா இருக்கேன்.
Very good.
வணக்கம் எல்லாருக்கும்.
Good evening, Abu.
வணக்கம்
Abul.
Great.
வணக்கம்.
Hasan sir, good evening sir. Good evening all. Super attendance in CGP under your leadership is doing great, Pare. I think Abul will continue the same. Ama. Now, first ever conference for 5 days. செந்தில் பயங்கரமான வேலை எனக்கு டெய்லி போட்டுட்டே இருப்பாரு எல்லா குரூப்ஸ்லயும் போடுங்க நான் நார்த் இந்தியன் குரூப்ல பூரா போட்டிருக்கேன் ஐ டோன்ட் நோ how many other states people join தெரியல எனக்கு
Totally more than 1500 registration
ஆயிருக்கு அதையே நான் போட்டிருக்கேன் அதையும் போட்டு போஸ்ட் டு கர்நாடகா ஆந்திரா கேரளா மூணுக்கும் போட்டிருக்கிறேன் தெலுங்கானாவுக்கும் போட்டிருக்கேன் அவங்களும் த்ரூ அவுட் இந்தியா இன்னும் நிறைய வந்தா தமிழ்நாடு சிஜிபி வில் கிரேட் ட்ரை ஹை Sendil sir is here, the organizer. Sendil Kumar.
Sir, good evening. Hello. Hello.
Good evening sir.
Good evening sir. கேக்குதுங்களா sir?
கேக்குதுங்க sir. Audible sir.
Okay sir. Thank you sir. Thank you sir. Thank you sir.
Good evening.
Good evening, Srinivas.
தெரியறதுக்கே எங்க வழி இல்லை அவ்வளவு உள்ள தாவிட்டு
Good evening, Srinivas.
அப்படியே ஸ்டாப் டாக்டர் செந்தில் குமார்
போட்டுட்டீங்களா ஒரு குட் ஈவினிங் போட்டுட்டு
Good evening, Jarakani sir.
குட் ஈவினிங் சார்
Good evening.
Good afternoon, Devanam.
Good afternoon, Anpal sir. Good afternoon.
Is Dr. Sendil joined?
Yes, sir. Joined, sir. Joined, sir.
Good evening,
Dr.
sir.
Devanam.
Sir, good evening, sir.
Is Dr. Rajesh Babu has joined?
Good evening, sir.
Sir, good evening, sir.
Hello, Sendil sir.
Hey.
செந்தில் சார் இருக்கீங்களா சார்?
Yes, sir. Yes, sir. We will start, sir.
எல்லாரும்
Just 2
அவைலபிளா
minutes.
இருந்தா ஸ்டார்ட் பண்ணிடலாமா
Yes, sir.
சார்?
We will start.
Sendil Rajesh Babu sir வந்துட்டாரா?
Rajesh Babu sir வந்துட்டாரு, sir.
Okay, fine. அவ்வளவுதான். Then fine.
Yes, sir.
Yes.
Sendil, will we start the meeting?
Sir, good evening, sir. Sir, President, sir, good evening, sir. Sir,
Good
now
evening.
everything is set, sir. You will just start, sir.
Good evening. Good evening. Shall we start?
Yes, sir. We will start, sir.
Oh, yes.
Meeting call to order. Now I request our CGP representative, Dr. Jayakumar sir, to give his Christian's prayer and IMA prayer.
தேங்க்யூ செந்தில் சார். Physician's prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray give skill to my hands, clear vision to my mind, kindness and sympathy to my heart, give singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the privilege that with the simple faith of a child I rely on thee. I am a prayer. May everybody be happy. May every one of us see to it that nobody suffers from any pain or sorrow. I do not ask for crown, nor I wish to be in heaven or reborn. I only want to alleviate the suffering of those people who are burning in fire of sorrow.
Yeah, thank you, sir.
Thank you, sir.
Yeah, thank you, sir. Now I request our CGP chairman, Dr. Sengitwan sir, to give his welcome address.
Good evening to all. It is today's our CGP conference is going to be started, and I welcome for this occasion. I welcome Dr. D. Chandamilpari, our president, state president, Secretary NRTR Tyagarajan, and other distinguished.
Now I request our
persons, Dr. Abul Hasan, Dr. R. Pallichami, and others. I also welcome the speaker, today's speaker. Today's our GGPCON conference. I also welcome all the delegates and all the participants for this occasion. Thank you. Once again, I welcome all the members for this forum. Thank you.
Thank you, sir. Now I request our State President, Dr. Sendamal Pari, sir, to give us introductory remarks for this CGPCON 2023.
Thank you. Thank you, Sandil. Good evening to all. Respected Chairman, Dr. Sangutuan, respected President-elect, Dr. Abul Hasan, State Secretary, Dr. Enatya Tyagarajan, and other state office bearers, Secretary, Dr. Sandil Kumar, Dr. C.P. Shanmugasundaram, Dr. Jayakumar, and other CGP office bearers, and our IMA members who are in this meeting. I am very much delighted to be here and to inaugurate this IMA CGPCON conference. That would be happen for 5 days online meeting. In the 5 days is a wonderful day, having very good topics that will be more useful for the general practitioners. Today, this program, the topics, two topics they are going to discuss. One regarding the Tamil Nadu Medical Council credit hours, how to log in the account, what are the guidelines of TNSB to the credit hours, things our CGP Secretary, Dr. Sandil Kumar is going to present. Another topic, head injury for general practitioners, Dr. Rajesh Babu, senior consultant neurosurgeon, and radiologist Dr. A. Anbaras. Both are going to talk about the guidelines of head injury and the imaging of head injury. I hope this program will be more useful. On Thursday, our national president also is going to join in our conference, and he will going to participate and give advice to us regarding this conference. Actually, I appreciate our secretary, Dr. Sandil Kumar, for his motivation and also to propagate this program to all peoples. He requested me to post this program to all groups by requesting our members to join. He expect only 1,000 members, but he reached out more than 1,500 delegates who had joined this meeting. It's a wonderful program. I hope this CGP will be forerunner to the national level IMA. I hope other states also follow our CGP meetings and protocols. With few words, I inaugurate this CGP conference. Thank you for the opportunity. Thank you.
Thank you, sir. Thank you, sir, for your kind words. And now I request our Secretary, Dr. Enatya Tyagarajan, sir, to give you a few words about the CGPCON.
Thanks, Dr. Senthil. Respected President Sendamal Pari sir, Chairman Sangutuvel sir, Senthil Secretary, and to various office bearers, Rabindranath, Raj Kumar, Shanmugasundaram sir, to all the rest of the office bearers. This is not only amazing teamwork, there's so much of detailing that's happening by Dr. Senthil over the past, I think he's not practiced at all. He's been on it and getting 1,500 registrations with each one paying 500 is a record of all sorts in either manual or Zoom. I think this is the record nationally. I'm not telling for any CGP alone, it's for any conference that's been conducted by the national IMA or by the state IMA. 1,500 registrations with 500 rupees paid registrations and spanning over 5 days. The entire organizing and the participation is amazing. And hats off to the entire team and especially Sendil for doing this. And each of the topics that have been selected for the next 5 days are going to be very useful for the general practitioners. And all of them have been they're being given by the best of the faculty that you can provide and best of the experience that we can provide in our profession. He selected that also very well. And Sengatwan sir and Senil sir, both of you done amazing work. And thanks to you for giving us the opportunity to take part in this amazing conference today. And right now we already have close to 900, I think, and we'll be crossing 1,000 for the first time. I think usually from the state office we get up to 500 only first, but Dr. Sendil had requested this time we are going to have 1,000, sir. So the participation limit should be increased to 1,000. And so we've increased it to 1,000 and I think we are close to that number already. And spread over 5 days, we'll be participating again on day to day. And today, amazing topics up on the line. I don't want to take too much of your time. Thank you for this opportunity. Thank you, Dr. Sendil and Dr. Sengatwan sir, for this amazing show. Thank you.
Thank you, sir. Thank you, sir, for your kind words. Now I request our President-elect, Dr. Abul Hasan sir, to felicitate the function.
Thank you, Sendil. Good evening, all. Respected President, Dr. Sendamil Pari, Secretary, Dr. NRTR Tyagarajan, Dr. Palasamy, immediate Pop Secretary, and Dr. Sengatwan, Chairman, and all the office bearers of CGP, and also my dear colleagues. I am very happy to see that our Tamil Nadu chapter of CGP has grown to this level of conducting a meeting of such a bigger magnitude. I have not seen a program in which more than 1,500 delegates are registered in the recent past. Congratulations to the team. I have got two suggestions. Number one, I have been attending almost all the programs of CGP, and they are with a wonderful content, with very nice speakers, and they are all available online. I wish all the delegates who are joined and also not joined get a copy of that speeches, and then they can watch them. They are really wonderful. And gone were the days when I was in CGP, both in Tamil Nadu and also national level. We used to travel quite a lot across the country, across the state, to conduct the CME programs in CGP banner. Now the Zoom has come, a shot in arm kind of help to spread scientific knowledge and wisdom across our members. So I wish all the delegates utilize these speeches for their upliftment of their knowledge. Secondly, through these programs, CGP has become quite popular in the state and also in India. So I wish CGP office better take measures to increase our membership because of this kind of ventures. It's only 1,000 rupees, and all the members who are joined today, please become member of CGP also, so that we will have more strength and we can even become number one in the country. I am very happy that I will be joining this program physically also on Thursday at Pollachi, and I will wish to meet you all again online. And I thank profusely Dr. Sendil Kumar and Sengatwan for inviting me to this, one of the very biggest event of CGP, most memorable and landmark event of CGP. Wish all the delegates have a good time, and thank you for the opportunity. Over to you, Sandhya.
Thank you, sir. Now, actually, I would like to brief a short note about the CGPCon. I really thank our President, Secretary, our President-elect, sir, and all our chairman, and all our wing office bearers. All of them were equally and very much actively involved in this particular conference. And this conference spread over 5 days. All days it is between 3:45 to 6:45 p.m. On Thursday alone, it is 7 to 10 p.m. This meeting is going to be a hybrid meeting on Thursday. I request all our members who are nearby our Pollachi can just join in directly also. We extend our warm welcome to you all. And now regarding this conference, we had a very good participation and registration. And as of now, registration stands at 1,750. And we are expecting more to increase by end of the conference. And regarding credit hours, so for all the registrations, we'll be getting ensured credit hours. Need not get panic, and all the details will be cross-checked several times, and it will be displayed and circulated among our WhatsApp groups. If any rectifications can be done, it will be done and then will be uploaded. And now I start the first session of the program, which is regarding TNMC credit hours. Okay. Screen share. Are you able to see the screen?
Not yet, Sandhya. Screen is,
Okay.
it
Yes,
just
sir.
says screen has started screen sharing, but the sharing has not happened.
Started but not correct.
It is seen now.
Yes. Yeah, now we are going to discuss about TNMC credit hours, frequently asked questions, and how to check our TNMC account. So we have circulated this several times before. Just for want of newcomers, I'm just explaining you again. Next. So now the thing is, like, who all need credit hours? So all practitioners less than 65 years, they need 30 credit hours for a 5-year slab. And 65 to 70 years, they need half the credit hours, which is 15 credit hours. Greater than 70 years, no need credit hours, but for the age between 65 to 70, or if it is between less than 65, they have to obtain credit hours for that particular tenure on pro rata basis. Next. So the first slab of credit hours, it started July 1st, 2012 up to May 31st, 2017. The second slab is between July 2017 to to May 2022.
Slides are not moving, sir.
Slide move. Madam. Huh? Yeah, it's not moving, sir. Okay. Yes, sir, we are trying to sort out. Meanwhile, I'm just continuing this session, sir, for want of time. Is it moving now, sir? So, how to compensate for first and second slab period credit hours requirement? The first.
Please put the previous slides.
Previous. Yes, sir. So we are in the third slab of credit hours, which is between.
Previous slide.
Yes, sir. So that is not much, sir, actually. July 22 up to May 27, that is the third slab of credit hours. So first slab is over, which is between 2012 to 17. Second slab is 2017 to 22. Third slab is between 22 and it is up to 27. Next. So first slab is how to compensate for deficit credit hours in first and second slab. So the first slab period, most of us were not aware about credit hours. It was Greek and Latin to us, and we were unable to fulfill the criteria. So the TNMC gave an option of paying penalty or for compensate for the deficit credit hours and nullify the minus credit hours. So for those who have not done this deficit credit hours, so the deficit credit hours have been carried forwarded to the second slab period. So suppose during the first slab there is 0 credit hours, so the total requirement is 30, and the second slab it is again 30. So it will be 30 plus 30 is equal to 60 hours. So now what if second slab credit hours are fulfilled, but there is a deficit in the first slab? So if cumulative credit hours are less than 60 hours, so as of now, it should be more than, 60 should be reached. Suppose we are more than 30 hours, but less than 60. So we are relatively safe because we can accumulate more and more credit hours in the future CMEs. And there is no option of paying and getting the deficit credit hours currently, and it will not be there in future also. So what will happen if credit hour criteria is not fulfilled? So now this is the question maximum our people are having in our mind. So at one point of time, we may not be able to revalidate our TNMC registration, which has to be done once in 5 years currently. So we have done our e-registration in 2020. So the next revalidation date falls on July 25. So there is a possibility to suspend the practice for 1 month in the current NMC draft. So this is in draft stage only, but once it becomes a official gazette, then depends how they have implemented this in the final gazette. So, but as of now, they have mentioned, which is circulated as NMC draft, it is mentioned there is a possibility to suspend practice for 1 month in the current draft. So now you can just see the medical registration certificate. So here it is very clearly mentioned, the right bottom side, valid until 3rd August 2025. So during this period, there will be a catch, and we may have to renew. Only with the adequate credit hours. So it is better always to accumulate the required credit hours. And it has become very easy now with a lot of CMEs and conferences coming on. So how can we get credit hours? So by attending physical CMEs, which were mostly during the pre-COVID era, and these will be conducted at branch level, state level, and also specialty conferences. So now there is more and more online CMEs which are coming. This has been conducted at state level by CGP wing, which is College of General Practitioners, AMS wing, which is Academy of Medical Specialties, and Academic Committee of TNSP. And how to know if the program is eligible for credit hours. So many times the organizers tell there is credit hours, but sometimes we don't get the credit hours processed, or sometimes it goes unnoticed also. So we can check this by asking for the accreditation certificate from the medical council. So it will display very clearly how much credit hours the program is eligible. And we are very frequently hearing about TNMC observers. So who are TNMC observers? TNMC will appoint observers for each program who will observe the program whether it is carried as per application and look for any unethical sponsors or advertisements and certify total number of participants. The participants will be awarded credit hours after organizers upload the attendance sheet as certified by the observer. So the attendance is very much important, and more, as time goes on, the medical council is very strict and the attendance is being asked. Even suppose the today's meeting is for 3 hours and it is around 180 minutes. They even ask minute-wise attendance of the participants. So in the Zoom, we are able to get the certificate, the report, which gives 180 minutes and it starts as low as 1 minute. So it is always safe to at least attend more than 50% of the program of the established duration. Next. And now, how to check the credit hours? So many people have their question in mind, and we have circulated this many times earlier. Just to recap. So individual account login, there will be a page in the website. So those who have TNMC account already, just go to the website, enter your registered user ID and password. And as soon as you enter inside, you will be seeing the CME credit hours, which will be displayed in the dashboard. So this is a sample dashboard. You will be seeing, suppose you have achieved the target of 60 credit hours. Congratulations. So that is a very big word to us, and we will be very much having a good relief. But some people, they'll be having less than 60. So it will show as 47 you have achieved. Furthermore, 13 is pending. So this is for the last 2 slabs. And the next slab will be, the current slab will be ending in 2024. Sorry, 27. So next. So this dashboard, you can see. So the second option is, some people, they didn't have TNMC account itself. So for them, this is the procedure. You just click the register here. So you can create a new account and exit. They will ask whether it is existing RMP, already registered RMP. So you have to use for a new, ask for a new registration. So these are the following details which we have to submit and keep it ready while creating an account. Next. And this is one important thing, maybe not for the members as such, but the institutes who can get the accreditation for running the medical council programs. So this is for institute login. So the institutes can log in with all the following criteria. So any institution can log in and register for the accreditation. Say, for example, in IMA Tamil Nadu State Board has its own account, TNMC account and accreditation to conduct the programs. Similarly, many of the branches have on their own. So, but sometimes what happens is small branches or new branches, they have not applied for, and for them, the procedure is this. Next slide. So we need to enter the basic details of the institution, who is the authorized person and their Aadhaar. Next. And association registered number, registration copy, institute logo, general contact number for the institute, and even for the contact number and email ID for the institute. Head of the institute. Next. And communication details. Next. So back. And so this is the procedure for creating new account for the institute. And now with new rules of NMC going to come, so the Tamil Nadu Medical Council has stopped giving accreditation to new institutes. The reason being, once they give the institute, it is valid for 5 years, and within 2-3 months period, it is expected that the new fresh NMC regulations will apply, In such a case, all the existing institutes have to apply fresh for the accreditation. So that is the reason they are doing like this. So in this scenario, what we can do is, suppose our branches do not have accreditation. Say for example, Pollachi branch, we give our account to nearby branches and they make use of our login account and we conduct the programs for them. So that is done currently. And in case if it is very emergency, if you give a declaration to the Tamil Nadu Medical Council stating that I am aware of this new NMC regulations and this validation accreditation will last for only a few months. If you accept for that, they can give temporarily. So now I'm going to the next topic regarding CME and CPD. As we all know, CME is continuing medical education, whereas CPD is continuing professional development. So just a minute, I'm going to share the screen. So CME versus CPD. So in India, CME is in existence, whereas in all abroad countries, particularly Western and American countries, CPD is the nomenclature there. So our government and our NMC is going to implement the CPD in future when the new regulations come in. That is like maybe another 2 months. Next. So now, what is CPD? What is CME? So CME is episodic events targeted to a group of learners, whereas CPD is based on self-assessment addressing educational needs for better healthcare. CME is speaker-centered, whereas CPD is learner-centered. So CME is based on the speaker who gives his lecture, whereas CPD is more towards a learner-centered. CME is mainly targeting technical skills and clinical management. CPD includes whatever CME is as of now, plus it is comprehensive for wide array of skills, which we will explain in the next slides. CME, the format is fixed, whereas CPD, it is based on active learning principles and it needs more intense planning. And CME is generally podium-based, whereas CPD is wide variety of methods customized according to the subject and target audience. Next. So CPD, delivery and review. So what are 3 categories of CPD? So category 1 CPD, it is 70% of the programs will be devoted to knowledge updates and skill development within specific area. So the current CME is of this category, whereas the other 30% is devoted to category 2 and 3. So this third category 2 is, it should be devoted to cross-disciplinary areas, bioethics, professionalism, communication, public health, policy, evaluating evidence, biostatistics, etc. So category 3 CPD, it is a self-directed online CPD for scholarly work. So these are the category 1. We can just see what all it's included. So CPD of category 1 includes conferences, symposium, seminars, workshops, and the credit hours ratings will be slightly different from the present one, but more or less it will be almost same. So it will be 0.25 credits per hour of active learning, and invited speaker, if it is from national or international level, he will be getting plus 1 credit hours, which is same as CMEs, and oral presentation will have 1 credit hour, poster presentation will have 0.5 credit hours. So we are currently we are not able to get any credit hours for posters and all. So for in a conferences, suppose the participants, delegates, they give poster presentation, they'll be getting 5 credit hours. It will promote and encourage all these people, students in future. Next slide. Category 2. So this is the new one, which is based on comprehensive skills. So 30% of the credit hours will be allotted to this. So as we discussed earlier, group activity through simulation, exercises, demonstrations on research, biostatistics, epidemiology, management of telehealth and telemedicine, communication skills, and clinical audits. So even management of hospitals, software management, everything comes under this. So there is a chance that the organizers can devote 30% of their CMEs, use the present CME in the 70% format, and 30% can be allotted to all these things. I am sure most of our doctors will need definite clinical expertise and technical expertise in these, so that we improve this and apply this in our future and current practice. So category 3, it is actually currently in the new CPD, the online programs cannot be more than 50%. So it is divided as online program should be less than 50 and physical should be 50, definitely 50. So that is one important change which is going to come. And so self-directed learning activities, it should not occupy more than 50% of credits. So in this, actually category 3, editor of a journal is recognized. He will be getting a credit hour. Author of a book, they will be getting credit hours, which are not there in the earlier CME format. So you can see in this, original article published in journals recommended by NMC, they will be getting 1 credit hour. Systematic review, meta-analysis will be getting, meta-analysis is the current trend, and they'll be getting 0.5 credit hour. Original article in PubMed indexed with IF, they'll be getting 2 credit hours. This is the highest one. And even reviews and letter to editor commentary, they'll be getting 0.25 credit hours. So this will improve the interaction among all our members, and it will lead to futuristic world in the medicine. So this is table 2, and this is one important thing. Now in CPD, the quality of the program will improve a lot from the current setup of CME, because they see the following criteria. The duration, it is important, whether it's 4 days, 2 days, 3 days, 1 day. And speaker assessment, the qualification of the speaker, content quality, content validity, whether it is appropriate for the present age. Then the communication skills, audience rating is also taken into account. Time management, whether the speakers are finishing the topics on time, academic environment, speaker reputation, speaker representation, and feedback response from the audience. So these things are not present in the present CME, whereas it will be there in CPD, wherein the quality of the program will improve dramatically and drastically. So these are the criteria and scores which are in the professional bodies framework. So whether it is registered, recognized by CPD committee, whether the institute is recognized by CPD committee, whether the program is state, national, international, how many events we are conducting, type of events, whether it is online or physical, and at any point of time, the 50% of the program should be always physical. And organizational transparency, which means whether the organization is transparent in getting the credit hours, whether it is genuinely operating, is there any black mark against the organization? All these things are taken into account. And even financial audit is also mentioned here, which means probably we have to be very clear in the accounts and everything, the organization, the institute which is getting accredited and conducting the programs. And we should have a website of our own, and also number of members. So how many members are attending the program, that is also important. So I think I have just briefed out about CPD and also the credit hours, which is mentioned in the current NMC draft. So now we move on to the next session, which is management of head injury. And at the end of the session, we will have extensive interactive session for both head injury management as well as even for credit hours. Thank you. And now I request screenshot. Now we are going to the topic where is imaging findings in head injury by Dr. Anbarasu. So just before going to the session, just a short CV of Dr. A. Anbarasu sir. I'm just going to read it. Though it is mentioned as short CV, it's a very long list. So Dr. Anbarasu is a consultant radiologist and director, RN Diagnostics Imaging, Coimbatore. He is present. He has in the past occupied the post of President, IRA 21, Vice Chairman, ICRA 21-22 currently, and previously State and Central Council member of IRA. So he is a consultant. He was a consultant radiologist and chief for MRI, pyramidal and SRL diagnostics high-tech scan for 10 years. And Sir has finished his MBBS, MDRD in LTM Medical College, University Mumbai, DNB, DMRE, DMRD, FRCR, FICR, and what else? And honors during academic career, Rohan Williams Gold Medal in FRCR. So, and it goes on. I think with the permission of Anwar sir, I am just ending the CV and over to you, sir.
Thank you very much, Sendil. Can I share my screen?
Yes, sir.
Are you able to see my screen?
Yes, sir.
Okay. Thank you very much, Sendil. That was actually, I was really amazed with your introductory lecture on CGP, and that was very, very crucial and very, very properly delineated how sort of we are going to change from CME to CPD credits and going to follow the international norms in this area. And the NMC is working on that particular aspect. And we at IRA also looking at that very seriously, and we have made a lot of teaching efforts to our radiology students and as well as the postgraduates and practicing consultants. And first of all, let me thank IMA State President Dr. Sendamil Pari and the Secretary Dr. N.R. Tyagarajan for their yeoman efforts for taking the IMA to next level. And of course, the CGP President and active Secretary, Dr. Sengutwan, as well as Dr. Sendil. Dr. Sendil is a very, very great communicator and a very good organizer, and no wonder that the CGP is now reaching a different level at all India and crossing more than 1,000 for any CME online is a great achievement. And as Dr. Tyagarajan has already alluded to, this is not an easy feat, and I congratulate him on behalf of all radiologists and as well as all the doctors to make this tremendous success. And IMA has been excellently active and leading by example by educating their members, and this is an important aspect which we have to be important, because education is one of the pillars of medical practice, and without continuous education, then there is always be a lag behind with our colleagues, or lag behind the government regulations, or even lag behind the NMC norms. And therefore, it is crucial that we update ourselves and be alert of what are the changes which has been happening. And with Dr. Devanand as the chairperson, I would like Dr. Devanand to take a couple of points on this before I start on the talk. Dr. Devanand.
Yeah. Good evening, Anbal. Good evening, all the office bearers of the IMA and the Sendil for organizing this conference in a very nice way. And head injury is very important, and it is one of the morbid conditions, more morbid conditions being produced because of the head injury. And it's the societal responsibility for this, and what is happening to the patient as such is very important. Radiology plays a very big role. Even though the clinical management is important, radiology will help you to guide, and it can give you the appropriateness criteria which to use, CT or MRI, that can help in the patient management and the clinical outcome. Everything can be determined along with the clinical aspects like the Glasgow score. The radiological findings will help you. And now Dr. Anbarsu is going to give a radiological perspective of what about the head injury, and we'll expect a good lecture from you, sir. Over to Dr. Anbarsu.
Thank you very much, Dr. Devanand, and Dr. Rajesh Babu will be taking over from me after this. So with that, I will just start sharing the screen again.
Sir, can you just switch off the animation effects, sir, so that the lines will not come in the screen while sharing?
Okay, I will just see. It's actually, what is happening is that the movement of the slides are not happening for some reason. When you go to the Zoom, just a second.
Yes, and now it's seen.
Yeah.
I think you can maximize.
Yes. Okay, right. Thank you very much again to everyone. Let us start with this head injury role of imaging. And that is something which is already known to everyone, but I'm trying to sort of link this with a treatment plan as well as the clinical aspects, because we have to think patient as a whole, not just images, as we all know that the patient coming to you with head injury, sometimes with the history of injury, but sometimes without history of injury, will become as an unconscious or semi-conscious patient. And that is where everything has to start, and how our thought process should be. And what is the role of imaging, and how will be the management of that particular patient is affected by the imaging. Not only that, there are various other parameters we have to look at, because patient is not just head. There will always be other areas of injury which could be happening, and that also needs assessment. And most of all, the most important aspect is to stabilize the patient first, and this is the most important clinical aspect.
Sir, can you just increase your voice, sir, little?
Yes. Can you able to hear me now?
Yes, sir.
My slide is again not moving for some reason. Let me just share it again. Are you able to see now? Somehow when it goes to the presentation mode.
Can you come out of the presentation mode?
Yeah, now it's working, I think.
Yes.
Okay. So the head injury, we are going to discuss about the clinical aspects and its limitations. We'll also see some images related to acute head injury, and also the subacute and chronic manifestations of head injury, and then what is the relevance to management. We'll go these 4 topics just to give clarity to our understanding. Again, it is not okay. So the clinical aspects, we all know that the head trauma is the leading cause of death in people under the age of 30, and that's a very, very important thing. It's sad that India is leading this particular aspect. Males have 2 to 3 times more frequency head injury than females. The classification of injury is primary injury as the skull fractures, contusions, intraction and extraction, hematomas, diffuse axonal injury. These are all the sort of primary injury to the brain and the surrounding tissues. The secondary injury, due to the injury to the brain, patient can develop hypoxia, ischemia, brain swelling and edema, raised intracranial pressure and lateral gliosis. Due to skull-based fractures, exposure of the brain tissue and CSF to the sinuses or mastoid can lead to formation of meningitis or abscess due to secondary infection. What are the imaging techniques available for us in a patient? We obviously has been come a long way from doing a plain radiograph. It has got its own limitations, because in acute head trauma, the absence of a skull fracture, which is the only thing which is shown on plain radiograph, or sometimes pneumocephalus, does not exclude a brain injury. Because there is no skull fracture, we cannot say that there is no brain injury. And the presence of a skull fracture obviously increases the risk of having an intracranial lesion. So you end up in doing CT anyway. So in a patient, in such situations, that indications for CT brain is not just a patient who is there with you, because the X-ray is something which will not give us further management. So you directly go for CT scan. That is the most important thing. Doing X-rays, in a cost-effective manner apparently helps, but if he thinks it is normal, then doesn't mean that patient is having a brain tissue injury or not. Indications for CT brain include suspected, if you even suspect there is a depressed skull fracture or open skull fracture, or any sign of ear bleed, any black eyes, any CSF rhinorrhea, any patient who is having vomiting more than 2 episodes after a head injury, age more than 65 years, irrespective of any other signs or symptoms, are the most important things. But the clinical modifiers, which I tend to use this particular word, clinical modifiers, is that road traffic accident. You can use all these criteria, but a patient coming with road traffic accident is obviously having concussion, lot of relatives around. Obviously, you wanted to make sure that there is nothing wrong with his whole body, not just brain. So these are all the clinical and decision modifiers which will happen. And the other important thing is that the patient conscious level, which will come to that at the last point. The alcohol and drugs, which increasingly happening and more population is addicted to alcohol, that is going to be an important modifier. You will not get a proper history. You will not get a proper, even some degree of whether actually it is actually head injury or something else, all those. So we have a problem when the patient has got alcohol. Old age patients may have a trivial head injury, but they can develop a subdural hematoma easily. So old age patients, you need to be very careful as well. And one of the thing is that they can actually have a manifestation of head injury, such as hemorrhage and hematoma formation after few weeks related to the injury time. And then the clinical assessment can be difficult. Think about a patient with alcohol in your emergency. Think about a patient with road traffic accidents having multiple injuries. The clinical assessment can be entirely difficult. And then the Glasgow Coma Scale assessment is very important. It guides us in many ways, and it helps us to prognosticate the patient, and it helps us to communicate to the clinical team and also communicate to the patient's relatives. Okay, this is the GCS. This means like these are all the possibilities, and therefore we wanted to hope that how he can improve, and we have to do all these things. So GCS gives a number which we will be able to communicate to the patient and say this is normal, which is 15 out of 15, and disease level means that there is something wrong with his brain or his functions. So that is actually a very important assessment and documentation. Coming to GCS assessment is an important aspect which is completely clinical. I'm sure Dr. Rajesh Babu will look into it. One important thing to say that GCS assessment need not always be accurate, and sometimes even be difficult, especially the eye assessment sometimes can be difficult. And therefore, when you are in doubt, your scanning is going to give us more guide to the management of the patient. And the most important aspect is to stabilize the patient before scan. The last thing we want is a death on the CT scan machine. So to stabilize the patient before the scan, explain the risk to the patients and their relatives, and tell them that the next step has to be CT scan, and all those things are important. Full stop. Sandil, I think somebody else is drawing those lines, not me. I don't know why it is happening. So CT is the choice of investigation, often combined with facial and skull-based thin sections for complete assessment, because patient with a low conscious level and also having a head injury, it is important and imperative that the skull base and facial bone assessment has to be done, because that helps them with anesthesia, helps them with intubation, and also helps them with skull base assessment. Fractures is something which is important for future directions like CSF rhinorrhea, and sometimes even putting an nasogastric tube. If there is a skull base fracture, you have to be very careful. So all those small things are going to be an important aspect. So CT brain can be important, but a little bit of skull base comment by the radiologist will always be very useful. So acute head injury can be classified into two areas, extraaxial and intraaxial, involving the brain tissue. One second, I'll just come out of this slide sharing just to take out.
So actually, there is one option where you can switch off the animation from your side, sir. So that nobody can draw over the presentation.
Switch off the animation.
Animation. Something will be there like animation effect.
Okay. Somebody is actually drawing that line. I don't know why. Okay, we'll see. Hopefully, I think probably people are moving the mouse and that draws on the screen.
Yes, sir.
Okay. Okay, extraaxial collections include subarachnoid hemorrhage, subdural hemorrhage, epidural or extradural hemorrhage, subdural hygromas, intraventricular hemorrhage. And this is an example of a patient with subdural hemorrhage. As you can see, on the left side, frontal and temporal aspects, there is a hyperdense area. Sorry. So again, somebody actually clicked on the mouse, it was automatically moving. Okay, I have to do this. I don't know how other people can control this. Where is that animation effect? Do you know?
Sir, any issues?
Now it should be okay. You are able to see now? Yeah, okay. So here we can actually see that left-sided subdural hemorrhage, which is seen as a hyperdense or whitish area.
It's not seen.
It's a presentation not seen, sir.
Okay, sorry. See, somebody is using the mouse in their mouse pad, it automatically moves the slides on my screen and your screen. I don't know how it is happening.
Sir, but actually, like that it won't come, sir. Only thing they can draw lines, that is possible.
Okay.
Anyway, sir, we'll just...
Let me just go get on with it, okay. Are you able to see now?
Yes, sir.
I see some lines are again drawn by somebody and the name is also coming who is drawing the line. Okay, see, again there somebody is moving it as well. That is the problem, it is affecting the flow. 1 second. One second, let me just do it this way. That way it is better, I feel. Okay. Sharing again. Okay. Now we're able to see?
Yes,
okay.
sir.
Okay, I think this way is probably better. I have better control. Okay, so the extraaxial collections include the subarachnoid subdural, which we have discussed. And we'll go to the next slide. So in the 30-year-old with RTA, what we are able to see is this: there's a complete left-sided subdural hemorrhage. The subdural hemorrhage is classically seen as a concavo-convex shape. You can see the mass of it. You can actually see the midline shift. The septum pellucidum region is now shifted to the little bit of right side. You can see the sulci on the left side are completely effaced. So there is a subdural hemorrhage which is there. And going to show you another case here is a large right-sided subdural hematoma, and the density is useful to know that this is a recent or sometimes within a hyperacute or acute phase. But sometimes if the patient is anemic, it may not be very dense even in the acute phase. So that's an important thing to be keep in mind. So here also it is causing significant mass effect and midline shift. And what is the indication? It occurs between, the anatomy is that it occurs between the dura and arachnoid. It can cross the sutures, but not the fox and tentorium. It is due to the disruption of the bridging veins. So it tends to be hyperdense in acute phase, becomes isodense to the gray matter in subacute phase, and then hypodense on chronic phase. It can extend along the fox and tentorium. That's an important aspect. Here we look at here, there is a hyperdense area we are located in a patient with head injury along the right tentorium, and also at the posterior fox in a patient with head injury. So these are all bled within the fox and tentorium, and they are always subdural. The extradurals do not go into the fox and tentorium. Coming to the management in acute SDH, this is something which is evolving and changing with guidelines, and Dr. Rajesh Babu will highlight on this. The simplest guideline will be if the thickness is more than 10 millimeter, or if the midline shift is more than 5 millimeter, then surgery to be thought about. This is only a guide because many patients with small subdural hemorrhages are nowadays conservatively managed, because sometimes the post-surgical recovery may not always good, because there is always an element of brain tissue injury which is there, which sometimes you may not see it on the early scans. We'll show you some examples of that in a moment. Looking at the extradural hemorrhage is a classic appearance. As you can see, it is sort of a classic, what we call it as a biconvex shape or idly shape. And when you start seeing these black areas within it, that means this is so-called swirl sign suggestive of an active bleeding, and it occurs at the site of impact. You can see the overlaying scalp hematoma, and there is always a fracture. 80% of them tend to have a fracture. The extradural hematoma is located between the skull and the dura, can cross the fox but limited by the suture lines where the dura is tightly attached. Arterial injury, commonly the middle meningeal artery is damaged. The biconvex shape, 85 to 95% of them will tend to have a fracture in it. Here is an example of another extradural hemorrhage, a large one with sort of swirl sign. You can see the depressed fracture. You can see this fracture is significantly depressed, and this is a classic example of a surgical extradural hemorrhage. If it is more than 15 millimeter in thickness and more than 5 millimeter, then it needs to have surgery. Less than that, it can be managed non-operatively, but needs close clinical follow, because it is possible that it could increase even with so serial CT is important to assess the decide on the management. Looking at the subarachnoid hemorrhage, it is due to most often due to rupture of the subependymal vessels. It can be post-traumatic or it can be spontaneous. It can occur from reflux of subarachnoid hemorrhage or contiguous extension of an intracerebral hemorrhage. So we should look for what is called the blood cerebrospinal fluid level. And here is an example. There is a blood which is there in the vermis gone into the ventricles. We can see this. There is blood CS of fluid levels are there. This is an intraventricular hemorrhage with the subarachnoid component started appearing, especially at the left sylvian fissure, and they will start coming out. The subarachnoid hemorrhage is often due to direct vessel injury or contused cortex or intraventricular hemorrhage. You should look at the sylvian fissure and intrapeduncular cistern for signs of hemorrhage. Here is an example. We are able to pick up this particular small contusion, but look at this little bit of blood in the subarachnoid plane, and there is another area of hemorrhage which is there in the subdural plane at the right parieto-occipital region. So the small areas of hemorrhages can be picked up in a high resolution CT scan. Here is a classic example of a subarachnoid blood. Patient actually bought with head injury and unconscious. Patient fell down suddenly, and there is a lot of subarachnoid blood. But what was actually, then we saw this hematoma, which is located in the anterior intrahemispheric fissure, which is classic appearance of location of an anterior communicating artery aneurysm. And when you do a CT angio, you are actually able to pick up this aneurysm, which is pick up this aneurysm which was there in this particular area. The reason is that the aneurysm rupture can lead to a fall, and following the fall, people think it is due to head injury. So that is one important aspect we have to think about. The intraaxial injuries include contusions, which can be hemorrhagic or non-hemorrhagic, intraparenchymal hematomas, axonal injuries, post-traumatic infarction, and brainstem injury. These contusions are the most important aspect. It is the most common source of traumatic subarachnoid hemorrhage, must involve superficial gray matter. Hemorrhage is present in 50% of the cases and tend to be at right angles to the cortical surface. Irregular bony contours. Wherever there is irregular bony contours, that is the area. If I show you this pathological slide, you will understand that. So you can see these black areas are the contused part of the brain. And where they are located, these are in the subfrontal plane. This is where the brain is against the anterior cranial fossa floor at the orbital plate of frontal region. This is the gyrus rectus region where it is against the floor of the anterior cranial fossa. This is the anterior part of both temporal lobes where it is against the sphenoidal wing and temporal fossa. So these are the common areas where the contusions tend to happen because of the force. The brain goes and hits against the adjacent bone, and the tissue get damaged. And obviously you can see that there as part of contusions. It can have non-hemorrhagic contusions on the right side, you can have hemorrhagic contusions on the left side. You can see post-trauma after some time, these areas can go into gliotic changes, or like a gliosis or a fibrotic change, which we tend to call it as gliosis. So intraparenchymal hematomas are local collections of blood, usually located on the frontotemporal white matter. Hematoma within normal brain. The one important aspect of intraparenchymal hemorrhages, again, it can be due to the injury or it can be spontaneous, which can lead to the injury. And if you look at the other differential diagnosis, is your hemorrhagic contusions and axonal injuries. Here is a patient with a large intraparenchymal hematoma with the blood going into the brain. Patient came with the fall and head injury, but when we do the CT, we know that this particular hemorrhage is probably primary hypertensive or other hemorrhages, but and then it can lead to this particular intraventricular extension. So I have to close this because somebody has drawn a line again. And even if I am not sharing it, the line is keep coming for some reason. Yeah. The names of the people who are drawing the lines also coming here. Okay, I think I probably have to.
So we can just stop sharing and come back again.
Yeah. Stop sharing and then come back again. Okay, we just go into the. Okay, this is the CT angio which I wanted to show you. You can see this little aneurysm at the anterior communicating artery, arrow marked, and that is the one which has blood leading to
sir,
the subarachnoid.
not
One second,
able
one
to-
second, one second, one second, one second. Sorry. Right share screen. Okay, able to see now?
Yes, sir.
Okay. So this is the slide which I was trying to show you earlier, the aneurysm which has led to the head injury and therefore rupture leading to the subarachnoid hemorrhage. So when we see the subarachnoid hemorrhage, we think it is due to trauma, but often we should look carefully the distribution of subarachnoid hemorrhage, the radiologist, and also if needed, think about doing a CT angio, ensure that the subarachnoid hemorrhage is not just traumatic or could be due to an underlying aneurysm. So there are certain patterns of subarachnoid hemorrhage which we will look for, a cluster of hemorrhages in certain areas, which will give us a clue, okay, this could be due to an underlying arterial bleed due to an aneurysm. And I was also showing this particular slide where there is an intraventricular hemorrhage secondary to the intracerebral hemorrhage with blood extending into the ventricle, causing mass effect and midline shift. The diffuse axonal injury is one aspect. So when you do a CT scan, you think the CT is showing minor changes, but the patient's conscious level is like 8, 7, 6. So there is a disparity between the level of consciousness and also the level of CT findings. So when you see the disparity, one important aspect to think about is the presence of diffuse axonal injury. Diffuse axonal injury can be missed on CT often because CT is not sensitive enough to pick up those tiny microhemorrhages and the tiny injuries to the gray-white junction areas. So 20% of them can show petechial hemorrhages, but MRI is the choice of investigation in this particular setting. So the MRI is very, very useful in picking up these areas. The reason being that due to acceleration and deceleration injuries to white matter and hypoxia, patient can have severe LOC at the site of impact. Grade 1 tend to affect in white matter, while grade 2 affects both white matter as well as the corpus callosum region, the midline compact white matter, and a brainstem is also affected in grade 3 diffuse axonal injury. If you look at here, initially within hours there are hemorrhages happen, axonal swellings happen, axonal bulbs happen, but in days and weeks there is formation of clusters of microglia and macrophages. In months and years it can lead to Wallerian degeneration. So initially if you go back and look at the initial CT, it will look almost normal in some of these patients. So here is look at this patient where we got a clue that patient has multiple small groups of clusters of petechial hemorrhages at not exactly on the gray matter, just a little bit deep to the gray matter if you look carefully, and these are all signs of axonal injury. So if you do an MRI in this patient, you pick up this tiny hyper intense area located just below the cortex, a classic site, and another patient with a hemorrhagic contusion, and look at this particular high signal at the level of the brainstem. This can be easily missed on CT. This patient also has got a subarachnoid hemorrhage, and there is a little bit of axonal injury here at the left temporal lobe as well. And this type of brainstem high signal edematous changes will picked up commonly only on MRI. And here is another patient who has got a hemorrhagic contusion, but look at the corpus callosum showing a high signal area. And that is again a sign of diffuse axonal injury, in addition to the obvious contusion, which may be showing on CT scan itself. But this particular area between the gangliocapsular region, again the gray-white junction, and then this particular corpus callosum region, white matter, we know that we are dealing with not only hemorrhagic contusion, but also grade 2 diffuse axonal injury. Another patient who has got same patient, actually we are able to see this. You can see the depressed skull fracture. We can see this gray-white junction edemas. And these areas are significant to look at on the MR. So the key thing for radiologists is when the CT findings are not matching with the patient's conscious level, then we have to ensure that suggest MRI for further evaluation to exclude diffuse axonal injury. The brainstem injury is often associated with DAI. It involves the midbrain and upper pons and usually hemorrhagic. Less than 20% of the brainstem lesions are seen on the CT. Now coming to the herniations, as you can see that when there is a mass lesion or when there is a hematoid or hematoma or some fractures, then there is a mass effect and midline shift, and the shift happens underneath the fox. So that is why it is called subfalcine herniation. But there is also herniation across the tentorium, this uncus, which is the medial part of the temporal lobe, herniates due to mass effect into the tentorial hiatus. We call it as the transtentorial herniation. And when there is a cerebellar lesion, often the cerebellar tonsil herniates under the level of foramen magnum. This is called the tonsillar cerebellar tonsil herniations. So subfalcine herniation is usually due to the cingulate gyrus going underneath. It can, one important aspect when you see that the anterior cerebral artery located there, when you start stretching and pushing it to one side, it can lead to infarct. So we are getting an infarct in a patient with head injury due to mass effect and midline shift. Here is a patient with subfalcine herniation. As you can see, there is a large subdural hemorrhage. There's a mass effect, there's midline shift. And if you do a post-contrast CT or CT angio, you will start seeing this anterior cerebral artery, which is getting stretched in this area. Luckily, this patient do not have an infarct, but they can develop an infarct if that artery is significantly compromised. Uncal herniation is due to displacement of the medial temporal lobe through the tentorial notch, and displacement of the midbrain can happen. Effacement of suprasellar system and widening of the ipsilateral pontocerebellar angles will be seen. And in that uncal herniation, the posterior cerebral artery is getting compressed. Here is an example patient with post-contusional edema. You can see this uncus is herniated, and there is a lot of mass effect and effacement of suprasellar system. You can see the CSF space surrounding the brainstem is distorted. The brainstem itself is rotated slightly. And this is the tentorial hiatus. We can see the uncus is very, very close to it. And this is the course of the posterior cerebral artery, which is about to start from there and going there. And when it gets stretched, then obviously it will get injured. The tonsillar herniation due to inferior displacement of cerebellar tonsils through the foramen magnum due to, it can also lead to posterior cerebellar artery infarction. The external herniation happens when there is a defect in the skull, when there is an elevation of intracranial pressure. Then the external herniation through this defect, like a burr defect, the brain can herniate, and that can lead to sometimes venous obstruction, because the cerebral surface veins can also get pushed along with those defects. When it comes to skull fractures, we always look for the depressed fractures, because it's been a traditional teaching that depressed fractures are the most important. But there are other fractures like linear fractures, sutural diastasis, and other skull-based fractures can lead to various issues. Here is a classic example of a depressed fracture. Any depressed fracture more than 3 millimeter or 5 millimeter, based on the books and papers you read, is become clinically significant, which may need further surgical management. Suture diastasis can be easily missed on CT. The sutures are very closely interlaced. When they are separated by approximately 1 to 2 millimeters, then it becomes very significant. That means there is definitely an injury. You can also appreciate another fracture on this 3D surface shading at the left parietal bone. In addition, there are clues with the skull-based fractures you will see here. What you see is the fluid level at the sphenoid sinus, air fluid level at the maxillary sinus. These are the clues to suggest that this patient is likely to have a skull-based fractures as well. Here is a patient who has got a defect, a burr defect, and the small fragments are there. Post-surgically, it was removed. And this particular defect is filled with CSF now. A temporal bone fracture is an important aspect which can be missed. It can lead to CSF otorrhea and sometimes even CSF rhinorrhea, because fluid which is seeping into the middle ear through the eustachian tube reach the nasopharynx, and then the nasopharynx, it can reach through the posterior nasal cavity and present as a CSF rhinorrhea. And it has happened in few patients. So we have to look for opacification of the mastet. There are two types of fractures, longitudinal and transverse fractures. Longitudinal fractures tend to cause conductive hearing loss, while the transverse fractures tend to cause the sensorineural hearing loss. And you can have complex fractures as well. Here is a patient where you will obviously see this fracture which is going through along the long axis of the temporal bone. But if you look carefully through this air pocket, the fracture is continuing through the facial nerve canal and almost reaching the middle cranial fossa. If you trace them in many patients, it can go along the margins of the sphenoid sinus as well. So this is an important aspect to be checked. Here is a patient who has got a transverse fracture through this. And this particular fracture, you can see it is going through the internal ear structures. And you can see the mastet is opacified. This is a transverse fracture through the temporal bone. It can lead to sensorineural hearing loss due to disruption of the internal ear structures. Coming to the subacute and chronic phase after head injury, you can actually start developing. In the subacute phase, you start seeing this, the subdural hemorrhage, you start seeing this classic fluid level. Anteriorly is the low density serum, and posteriorly is the high density globin and heme. And this type of hemostatic appearance can lead to the formation of fluid levels. This is a sign that this has happened approximately 72 hours or 48 hours before. That is a subacute phase of hemorrhage with sedimentation. Another classic example of a subacute subdural hemorrhage on both sides, forming fluid level, and both are actually causing compression of bilateral cerebral tissues. This is the chronic subdural where the fluid level started disappearing, and you can see it's becoming more blacker, and again it is causing significant mass of it and midline shift. So all these 3 patients should have surgery because of the fact that irrespective of the time and irrespective of its density, it is actually causing problem to the patient. Other delayed sequelae can happen includes caroticocavernous fistula. I told you earlier about infarction, atrophy and encephalomalacia. When you start having atrophy and encephalomalacia and gliosis, this can lead to seizures. That is one important complication of the head injury. And of course, infection, especially when they have a skull base fracture. Here is an example of a caroticocavernous fistula. As you can see in this patient with the previous history of trauma, there's dilatation of the superior ophthalmic vein, ballooning of the cavernous sinus, and this is a classic example of a caroticocavernous fistula, which we pick it up on post-contrast CT scan. And here is a patient who has got post-traumatic infant, had a head injury, but you can also see here, this is the post-trauma and contusion, but he started having a little bit of right-sided hemiplegia on the left perisylvian fissure, started having some infarct, like probably due to some compromise or brain swelling. But you can also see there is a large infarct which is developing at the posterior communicating artery territory, and there's a big brain swelling has happened, probably started compromising part of the MCA, part of the posterior cerebral artery as well. So these are all some of the post-traumatic infarcts which can occur. And this is the encephalomalacia. Patient had a head injury, the brain is injured, and patient had a surgery. You can see the patient had a craniotomy defect. All this done, patient has sort of recovered, but following recovery, the damaged brain tissue never recovers. It actually forms the gliotic and the fibrotic change. In other areas, this is called gliotic change. As a result, there is cortex is thinned out. The CSF has filled part of the space to fill those vacuum areas, and you started losing all the gray-white differentiation areas. So what we have covered so far is we have covered the clinical aspects on limitations, and we have covered acute head injury and its imaging manifestations, which includes intraction and extraction manifestations, and subacute and chronic manifestations, which include this caroticocavernous fistulas, chronic subdural hemorrhages, and also various other complications, including gliosis. And the relevance to management is here. Anything which is causing mass effect and significant midline shift is of an important thing aspect to inform the neurosurgeon. Serial head injury CT follow-up is an important factor which will decide on difficult patients. Some patients do not fall in this category or that category, so you have to be very, very careful in serially following. Make sure the patient's relatives are explained that this is the status, and this can go either way for surgery. If it increases in size, if it is causing more if it is causing more deterioration in the general condition of the patient and the GCS score. So all those explanation is very, very important. So what is the take-home message? The key contribution of CT is to decide on surgical or conservative, but the close interval follow-up to assess the progress is very, very mandatory. The clinical assessment in acute setting, especially in the alcohol and RTA situation, can be very difficult, but stabilization of the patients is the most important thing before CT. And then late manifestations and late bleeds can occur. Neurological deficits, cranial nerve palsies, and seizures are also known to occur following head injury, and that itself is a separate science. As you all know, neurologists have a lot of effort in treating these seizure patients in post-trauma. The cranial nerve palsies following trauma sometimes do not recover. With this outline about the head injury and CT and MRI manifestations, especially the MRI, which is useful for diffuse axonal injury evaluation, I would like to stop this lecture, and thank you very much for listening.
Thank you, sir.
Thank you, sir.
Devanand?
Yeah.
Sir, we will have some QA session after the next talk, sir. We'll have.
We have discussion after that? Yeah, okay, fine, no problem.
Yes, sir. Now I invite our next speaker, Dr. Rajesh Babu, sir, who is also our AMS Wing Secretary. Sir has finished his MBBS and general surgery and MCH neurosurgery, and he is a consultant neurosurgeon at Ganga Hospital currently. Earlier, sir was heading the neurosurgery department at KG Hospital and also in Institute of Neurology, Chennai. Next. And sir has undergone advanced training in advanced neurosurgery in All India Institute of Medical Sciences, New Delhi, and also a certified instructor, comprehensive trauma life support of international trauma care. Sir has attended many conferences and won many prizes, awarded Neurotrauma Institution Award 2017 at the NTSI conference, a national award to Ganga Hospital, where he is working as a consultant. During his period in 2018, National Indian Medical Association, New Delhi, awarded 3 awards to IMA Coimbatore, including the President's Appreciation Award, Best Scientific Program. And sir is also currently Secretary of Neurosurgeons Association of Tamil Nadu. Over to you, sir. Sir, you can start. Meanwhile, a small announcement. Registered participants, if they can put their registered number alone in the chat box, as we have all your details in the Google form received as well as through the mail. You can enter only your registered number in the Zoom chat box as well as YouTube live chat box. Thank you.
Good evening, everyone. I am audible, sir?
Yes, you are audible.
My slides visible, sir?
Yes, sir.
Good evening, everyone. I like to thank our Tamil Nadu IMA chapter president, Dr. Sendabil Pari, sir, and secretary, Dr. NRTR Tyagarajan, sir, and the CGP wing, the chairman, Sengotuvan, sir, the secretary, Dr. Sendil, sir, and their joint secretaries for giving me the opportunity to present about the guidelines in the management of the head injury. See, in the head injury, our IMA AMS usually presenting with the video clippings every month. One such video clipping is for head injury. We have presented this video clipping, which is showing the importance of the seat belt and how we are driving the vehicle without the proper vision and meeting with the accidents without following the safety rules on the street. That is what happening, and we are seeing a lot of accidents which are happening blindfolded. See how the accidents are happening, and all these accidents leads on to head injury and also the polytrauma and all the complications. This is what usually are happening. We, IMA AMS, Academy of Medical Specialty, usually every month we used to give a video based on the national and international days. This is one such video which was sent on the Road Safety Week celebration. At the time, this video has come, and which is showing the blindfold of the people who are traveling on the road. Commonly, the accidents are happening because of the carelessness of all the people who are driving the vehicles, not following the driving rules. So don't drive blind. We want to save the life. And then another one is the accidents because of the animals. See, a two-wheeler is running and the horse is crossing and which is hitting. He is one such patient who came to me. Luckily, this fellow had a closed head injury and he was treated conservatively. And regarding the head injury part of it, before going to the head injury, first of all, we should know that when a person is having a injury or meeting with an accident, immediately we have to examine him. At the spot of the injury, we can examine. It can be in a village or in a city or in a higher centers like that or nearer to our hospitals. At that time, immediately we should examine them for hypoxia or hypoventilation or hypotension, the anemia, the seizures, and the spine instability. Because if we are suspecting the hypoxia or hypoventilation, we can do the respiratory rate examination and ABG if possible and correct it accordingly. If the hypoventilation and all those things are there, even on the spot, we can, if facilities are available, we can do intubation. And if you suspect hypotension, then we can give the volume replacement. Then regarding the anemia, we can find out the paleness of the patient. Immediately we can give the transfuse the blood. And seizures, if they are having seizures, anti-epileptic drugs are to be given. And main thing, when they are having meeting with an accident, people used to lift the patients in a haphazard manner. If you do like that, there will be chances for spine injury. For example, one of the patients who met with when he was driving on the Ghat road, there was an accident and he fell down into the hairpin bend and he fell into the Dila. And subsequently, at the spot of the injury, he himself was telling, now he has recovered, and he is telling, I was moving the limbs when I was meeting the accident. And after that, they brought me up and put me in the ambulance. By the time I reached the ambulance, I was not able to move both the lower limbs. That's what he was telling. But he was able to move the upper limbs. That's what he was telling. And so the spine is very important. And we have to transfer the patients with many caution. And so the management of a head injury is a teamwork, trauma team, which should be consisting of the duty doctor, the intensivist, the anesthetist, the general surgeon, the orthopedic surgeon, the plastic surgeon, and the neurosurgeon. All these people should be there. That means it should be a center where all the facilities are available. Then only it will be very nice to easily treat for any problem or any patient, any things the patient is suffering from. And so the patient is as per now transferred and he is reaching one hospital. And first we elicit the history. It is the dangerous mechanism, the acceleration injury or deceleration injury. We should find out how much the force the accident has created. And secondly, we have to see the pupil, then closing of the itosis and the vision. And other things which we need to examine are motor examination, Glasgow Coma score, and scalp injury and associated injuries. We will see one by one. First is the pupillary size. So immediately, if you see a patient, we should see the pupil, the size of the pupil. on the both the sides. Usually, if there is dilatation of the pupil, there will be a compression of the cerebral hemisphere on that side, and so there is dilatation of the pupil. And so, if a person is having extradural hematoma, EDH, or subdural hematomas, SDH, they will be having the dilatation of the pupil on that side. And if the patient is developing the dilatation and ptosis, it is an oculomotor nerve paralysis. When there is a third nerve paralysis, there is ipsilateral ptosis with the dilatation of the pupil, and there will not be any movement of the eyeball except the lateral movement of the eyeball, which will be seen. And then very important thing is checking for the vision. The vision, we have to check both the eyes separately. Each eye to be checked for vision by closing the other eye. If altered sensorium, attenders are to be explained. For example, when a person is coming with a head injury, immediately we should close one eye and ask the number counting. And then close the other eye and do the vision checking. That's what we have to do. If they are conscious, we can do that. See, sometimes when I see the patient is getting admitted in the hospital, and the duty doctors there will see the patients immediately in the night time after we leave from the hospital. And next day only we see the patient. Suddenly, one or two occasions, it happened like that. I was able to make the defective vision on the eye only after 12 hours, 20 hours after admission. If we say like that, at the time, the attenders will be much irritated and they will come for fighting with us. That is the problem. Very, very important thing is, if the patient is unconscious, no problem. We can explain the attenders that about the vision we are not able to check up. There is a possibility he may not have the vision at all. Like that we can tell. And each eye has to be checked for vision by closing one eye separately. When we ask, usually our habit is just to show the fingers and ask them, how many fingers? Immediately they will say. But one eye may be a blind. Or one eye may be having a cataract also, some of the patients. So we should be very, very careful. Some people may be having a corneal opacities also. Then coming to the motor examination. The motor examination is, if the patient is cooperative, we can check the muscle strength, motor strength. If the patient is uncooperative, it is unconscious patient, we have to give the noxious stimulus. If the patient is cooperative, the motor strength can be tested. One thing we can test is, on the bedside, they will be moving all the four limbs. But if you ask them to do the hand grip, you have to ask them to do the hand grip immediately. The two fingers, we have to ask them like this to do it, like this to do it, and pull and see. And even if it is a minor weakness is there, they will not be able to hold our hands, our fingers tightly, and they will leave it up. And that shows there may be a chances for cervical cord injury, and we need to order for immediately the MRI scan also for the cervical region and also spine. And in uncooperative patients, the noxious stimulus, that is the eyebrow pressure or sternal pressure or nail bed pressure. These are all the dignified manner we are doing. And pinching, which is a little bit cruel like, and if attender sees that, they will become irritated. So we should be very careful in doing that. And coming to this muscle strength, the hand grip also. So when you ask them to do the movement of the limb, if it is conscious, they will be able to do the movement of all the four limbs very casually. But if you ask them to do the catching of the fingers, they will not be able to hold it tightly. They will have mild weakness and they will leave it off easily. So by this way, we can find out the cervical cord injury. Even sometimes the spine doctors also seeing, they may also miss this finding. That is a thing which everyone has to do it in all the patients with head injury very carefully. Then coming to the Glasgow Coma Scale. Glasgow Coma Scale is the benchmark which is of much use. And in this, we can know the severity of the head injury. If it is less than 8, it is severe head injury. If it is 9 to 12, it is a moderate head injury. If it is 13 to 15, it is a mild head injury. So coming to the Glasgow Coma score, how to see? See, for example, it is in the people above the age of 4 years and below the age of 4 years. Here you can see the 3 responses are eye-opening, motor response, and verbal response. We used to say EVM. EVM, eye-opening is 4, verbal response is 5, and motor response is 6. Totally, it is coming to 15. The numerator is what the patient is having, and the denominator is what the actual benchmark score of 15. So, in the eye-opening, below 4 years and above 4 years, eye-opening, spontaneous both sides. To the eye, verbal commands is eye-opening. The react to voicing below 4 years. And to pain is same, react to pain same. Unresponsiveness. So eye-opening unresponsiveness is 1 and spontaneous normal, rest things in between. Same way the verbal response, oriented. Here, smiles, follow the object and interacts. Children. Disoriented. Here, wise but consolable, inappropriate. Here, inappropriate words, inconsistently consolable and moans. And here, incomprehensible sounds, inconsolable, irritable. And here, unresponsiveness, that is the 1. So 1 to 5. And motor response are obeys commands and spontaneous obeys commands is 6. And unresponsiveness is 1. Here, 2 is extension to pain. This is the decerebrate response, extension to pain. And flexion to pain is both. It is the same as thing which is called decorticate response. And withdraws to pain is 4. And localizes the pain is 5. And obeying commands, here spontaneous obeying commands is 6. So, eye-opening, motor response, and verbal response, EVM is 4, 5, 6. E4, V5, M6 is the normal thing. And if it is the patient is having the abnormality, it can be recorded. So how we mark in the chart? This is an example of a chart where here you see the time, the patient name, ID number, and all those things. Here the time we can put it and we can put the responses. At the same time, you see the pupillary response and movement of the limbs. All these things. It is reaction, non-reaction, ATT. So when we are putting the verbal response, if the patient is intubated, we put it as V underscore is T. And eye opening score, which is 4. And motor response is 6. And verbal response, if it is tracheal, the endotracheal tube is put, it is T. So Glasgow Coma scale is very important. That's why I am going on stressing about it. A patient is being comatose if he does not open his eyes. If he does not obey commands and he does not utter recognizable words, it is called comatose. Severity of coma may be assessed by assessing a value to the eye, motor response, and verbal response, and summarizing all these 3, scoring 15 marks. By repeating the examination at regular intervals, progress may be monitored and any deterioration suggesting interactional complications and recognized at an early stage. The eye opening, already I've told, 4 to 1, best to motor response, 1 to 6, and verbal response, 1 to 5. The coma score is EMV, with a value of 3 being worst possible response and the 15 being the best response. A value of Less than 8, 7 indicates severe coma, 8 to 12 moderate coma, that is 9 to 12, and 13 to 15 is mild. Severe injuries are frequent and more patients who develop hematomas requiring surgery are classified as moderate or minor on their admission in the hospital. So, why Glasgow Coma score is important? It is because it is simple to use. It is a predictive of outcome, low intra-observer variability, rapid assessment of the neurological status, and guideline for the initial management. That is of much useful, and which was actually, once again, the Glasgow Coma score is severe head injury, less than 8, moderate is 9 to 11, and minor is 12 to 15. And if the Glasgow Coma score usually is less than 8, it needs intubation. So the Glasgow Coma score was initially invented by 1974, created by Graham Teasdale and Brian Jennett at Glasgow. That's why it is called as Glasgow Coma score. The verbal response is the main thing which changes in this of the eye opening, motor response, and verbal response. So that is once again told. No response is 1. Moans to painful stimuli is 2. Cries to painful stimuli is 3. Irritable or continuous cry is 4. And coos or babbles normally is 5. Then coming to the physical examination in head injury. General physical examination. First, we have to see the visual inspection of the cranium. We should wear nicely the gloves and palpate the head and see whether there is any abrasion, whether any laceration or any cut injuries are there. And then evidence of the basal skull fractures, the raccoon's eyes, the battle side, the CSF rhinorrhea, the CSF leak from the nose, and CSF arteria, the leakage of CSF from the ears. The laceration of the external auditory canal, and check for the facial fractures, the Lee-Coat fracture, the orbital rim fractures. So coming to the scalp injuries, scalp hematoma, usually they will have closed wound, but there will be a bulging will be there, and a scalp abrasion and a scalp laceration. In the scalp hematoma, one thing that is misleading in a pediatric head injuries are, there will be a scalp hematoma. If you palpate in the center of the scalp hematoma, you will feel as if there is a fracture like. But usually in children, when it is a depression is felt, it will not be any fracture there. This is a mimicker of a fracture that happens. So you should be very careful in coming to a conclusion before telling to the attendants. Mostly scalp hematoma will be there. And then scalp abrasion is usually a redness and a blackish discoloration and all those things. And the scalp laceration, clear cut wound will be there. Coming to the scalp laceration, there may be a small laceration or a large. Small lacerations, what they need is just the inspection, cleaning of the wound, and then suturing. The large lacerations, sometimes you see here, it is exposing it is only a laceration, degloving laceration. It's exposing the brain, it is exposing the bone, and also fascia and all those things are there. And even here you can see the discoloration of the brain matter. See, that's what happening. So it is very, very careful. If it is left open, the brain, when it is exposed to the atmosphere, it dies and produces more cerebral edema, and it produces more of a defect over the cerebral hemisphere. That's why very, very important. If you see a laceration in any part of the thing, immediately after injury, it is better to just clean the wound and put the suturing. And nowadays, it is very easy to do the suturing. We have got a staples available. Just you clean, just pour the saline, bottle saline, you can pour it up, clean the area, just apply the scalp flap, and then apply the staplers. That is a very important thing, which will be very much useful. So the scalp laceration, early suturing helps, prevents infection, prevents cerebral edema, Unfortunately, this patient actually had injury at the time of around 2 o'clock, 3 o'clock, and he reported to the hospital only after 6 o'clock. And then, so he was not having good response at all. Now, regarding the associated injuries, chest injuries, abdominal injuries, the long bone fractures, all these things are there. So, associated injuries is a very, very common thing which happens in case of head injury because the patients may not be having a normal consciousness. They will be having an altered sensorium, and sometimes we may not be able to make out everything on a stretch immediately. And we make out the chest injury by moving the saturation, which is low, and abdominal injury also. Long bone fractures we can make out because of the deformities which happens. And abdominal injury, sometimes we have diagnosed on day 2, day 3 of injury. Recently, we had some of the cases, hollow viscous injury, which we missed it. That is the very important thing. And so, when the patient coming with a head injury, we have to tell the attenders, if the patient is conscious, then it's okay. They will be telling here pain, there pain, all those things they will tell. But if they are unconscious, they will not tell. We only have to find out by taking the chest X-ray, by taking the abdominal scan, by taking the skeletal survey. That is the very, very important thing. And then in the clinical examination, physical examination, the other important thing is radiocervical auscultation. Very, very important thing. That is carotid artery dissection. We will have bruising. And globe of the eye, traumatic keratoconus fistula, which our Anbarasa sir has shown it. That is, they will have bruise. When you keep the stethoscope in the eye, there will be a bruise will be here. Physical trauma to the spine. Already I was telling more about the hand grip. And another, that is the minor thing which we make out. The classical monoparesis or monoplegia, and there is one limb is totally weak. Paraplegia or paraparesis, there is a weakness or mild weakness of the lower limbs. And quadriparesis, weakness of all the four limbs, that is a cervical cord injury. All these things we need to examine. This is a routine when you see a person with a head injury. And then regarding the evidence of the basal skull fracture, which I was mentioning, that is how we make out. See, the raccoon's eye. This is called the raccoon's eye. See, this is a small animal, which is called raccoon. See, its eye is like this. Same way when you have the basal skull fracture. This raccoon's eye is a classical finding in the anterior skull base fractures. We used to see this raccoon's eye. That is very, very important thing. Even in exams also, previously they used to ask like that, anterior skull base fracture, raccoon's eye. Even from MBBS level to the higher level, when we are appearing for the exam, they will ask questions from this neurosurgery department like this. The another thing is evidence of the skull base fracture is battle sign. Redness or ecchymosis around the mastoid region and around the ear. That is called the battle sign. Battle sign is the very important thing, which indicates the fracture of the middle and posterior cranial fossa. Very, very interesting. And then another things which we need to examine are once again are granular examination, grossly, optic nerve examination we can do. That is vision, already told. Then pupil, then facial nerve. Facial abnormality we can make out. Patient may be having deviation of the angle of the mouth to one side and absence of expression in one side of the face. That is diagnostic of facial nerve. By seeing the patient, and sometimes they will be having infrequent wrinkling of the eye on that side. And then fundoscopic examination, you see the fundus, we may be able to see the retinal hemorrhages and all those things. And then the level of consciousness, once again I told, Glasgow Coma score and the check for orientation. And then motor examination, already we have covered it in detail. And then coming to the sensory examination, this is our academic purpose and also to rule out the other spine injury like that. So cooperative patient, pain, pinprick, touch, hot and wool, major dermatomes. Uncooperative patients, central response, grimace to painful stimulus. And then regarding the reflexes, deep tendon reflexes, then plantar reflexes, Babinski sign, and then spinal cord injury, the anal reflex, and the bulbo-cavernous reflex. These are all some of the things. The anal reflex is the plantar reflex. Everyone knows that elicitation at the plantar site. The anal reflex, you put a finger into the anus and scratch the skin around the anus, there will be a constriction. That is the one thing. That is anal reflex. And bulbo-cavernous reflex is the same way. When there is, you put your finger into the anus and pull the catheter, there will be the tightening of the anus will be there. That is the bulbo-cavernous reflex we can elicit. And the categorizing of the head injury, once again, we have already told. And then, so these are all the things which we have come across a clinical examination grossly on a patient who is presenting with a conscious level or unconscious level, and we examine them and come to a little bit conclusion. But there, our treatment will not end. There only the treatment starts. We will start with an IV line and we will be supporting. And if this Glasgow coma score is less than 90, we will intubate. Saturation low, we will ventilate, and all those things happens. And also we will put the Rayleigh tube to aspirate the stomach. These are all the things we usually used to do, and also catheterize. Catheterize, Rayleigh tube, and then endotracheal tube if it is unconscious. If they are conscious, we will wait for all these things. But we can come to a conclusion only with the imaging. That's why I asked that Anbarasi sir to first give his light, and then I wanted to talk. So the radiographic evaluation. Here, the what X-ray you should take. Routinely, the skull X-ray is AP view, lateral view, and sinus view. But in a case of head injury, the sinus view is very, very difficult. It is called a swimmer's view. But AP view, lateral view, you can take easily. The advantages are categorize it is a mild, moderate intracranial injury, and also to see whether it is a depressed fracture or elevated fracture, that we can. But the disadvantage is we cannot make out any internal lesions. See, when a person is coming, and when we are suggesting in our OP, even you also will be seeing lot of patients, sir, விளையாடிட்டு இருந்தோம் சார், கீழே விழுந்துட்டோம் சார் அப்படிம்பாங்க. அப்போ வந்து அவங்களுக்கு ஸ்கேன் எடுக்கிறது வேண்டாமா அப்படிங்கிறது டவுட் நமக்கு வரும். பட் நம்ம வந்து சொல்ல வேண்டியது வந்து இல்லைங்க, கீழே விழுந்துருச்சுங்க, மூளையில் அடிபட்டிருக்கிறதுக்கு ஸ்கேன் எடுக்கணும் அப்படின்னு சொல்லுவோம். அப்போ அவங்க கேட்பாங்க, எக்ஸ்ரே எடுத்தா? எக்ஸ்ரேல ஒண்ணுமே தெரியாதுங்க. மூளைக்குள்ள அடிக்கிறது தெரியணும்னா நீங்க வந்து ஸ்கேன் எடுத்தா தான் தெரியும். You have to take the scan. Then only you will be able to see the intracranial problems. That's the very, very important. So you have to tell them the importance. And then, and nowadays, people are going through the net and all those things. And each and every one patient, when they come with an idea. And even before telling to take a scan, they tell, doctor, we will take a CT scan. We want to rule out any head injuries. They come for the scan and they do it. Nowadays, people are very, very much wanting things to do it. And in X-ray skull, what are all things you see? Some of the things I am depicting here in the skull fracture, you can see elevated fracture or depressed fracture. The air packets or foreign bodies of the skulls can be seen. Here a fracture and there is a small air packet, pneumocephalus. When the air packet is there inside the skull cavity, you call it as pneumocephalus. They will be in the cerebral hemisphere or into the ventricles. See here in the X-ray skull. See, this is the air packet which is seen inside. Even in X-ray it is seen. Previous days, in olden days, we used to say, one test which is called as pneumoencephalogram. That is one type of a test where at the time the CT scan and all those things were not available. At that time, people used to do what they do is they do a lumbar puncture and inject air into the spinal space, and then they will take an X-ray, and then the X-ray it shows the air packet inside, and based on the position of the air packet, they can come to a conclusion of whether there is any intracranial pathology or not. That's what they were doing. But this picture is similar to what we expect as pneumoencephalograph. Then, regarding the spine X-ray. Spine X-ray is cervical spine. What we have to take is, we have to take a AP view and lateral view. We have to include CV junction up to C7 and T1. That is very, very important thing. We should not just like that take only the cervical spine itself, but it should include both. And thoracic and lumbar spine also we can do it. That is also very important. In X-ray skull, a young man admitted with history of RTA on examination, laceration over the scalp with the brain matter seal coming from the blood mixed with the blood. X-ray skull taken. See here the irregularities. These are all some elevated and depressed fragments with a small air packet, which is, see, all these things are seen. Classical X-ray, very interesting X-ray, depressed fracture, elevated fracture, and air packet, pneumocephalus. This is a very, very interesting picture. No one might have seen this X-ray, I think, if the audience, because it is a rare X-ray. Patient present with head injury, ENT bleeding present, was treated at a nearby hospital for 10 hours. X-ray skull taken. What is the diagnosis? That is the very important thing. See, are you able to make out anything here? Here. These are all the things. What are all that? That is a Rayleigh tube. Rayleigh tube is seen inside the skull cavity. So, when a person is presenting with a head injury, better avoid the Rayleigh tube passing through the nose. You should pass through the Rayleigh tube only through the mouth. That is what nowadays all the anesthetists are practicing. The intensivists are practicing. In most of the hospitals, they are practicing like that. Because even in patients, all right, if you put the Rayleigh tube through the nose, there is, if you are going to keep the Rayleigh tube for a long time, there is chances for sinusitis. So that's why, and above everything, the head injury. You see, when a person is having a basal skull fracture, if you put the Rayleigh tube, sometimes it can go into the skull like this. That is very, very important thing. And this is a very, very rare picture. And then X-ray C-spine. See in the cervical spine, a nice fracture you can see. This is the axis. Axis got a fracture. Okay, very interesting. And then coming to the indications of the CT scan. Very, very important thing. Glasgow Coma score less than 15 after 2 hours of injury. When they are coming, Glasgow Coma score 15. After 2 hours, it is less. Immediately do a CT scan. Evidence of any open skull fracture. Open skull fracture means there will be chances for lacerations. There may be a brain matter coming through the wound. There may be a leakage of CSF through the wound. All these things can happen. In that case, we call it as an evidence of open fracture. And then signs of basal skull fracture. Basal skull fracture already I was telling. CSF leak through the nose, CSF rhinorrhea, and here CSF arteria. Patient presently vomiting. Immediately do the CT scan. Age more than 60 years, unless 15 years, do the CT scan. Dangerous mechanism. Fast vehicle going and hitting. That is also a thing. And then suddenly head colliding on the face surface, you have to take. Or any of the foreign body. For example, cricket ball coming from there, or a stone coming and hitting on the head. You take a CT scan like that. And then if there is an associated injury, for example, a person is having a chest injury, abdominal injury, lung bone fracture. Because when they are falling down from that vehicle, they will not know where are all the things the body is touching onto the surface or the road. Very, very important thing. That's why, even for example, one time I was taking my wife in a two-wheeler and she was sitting behind. And suddenly it was around 8 o'clock, 8:30. And suddenly what happened was there was a speed breaker. On that, it was in the dark, it was not known. And so I climbed up and down. And suddenly she started telling, I am slipping, slipping, slipping. She was catching my shirt and then suddenly they slipped from and fallen down. That means the vehicle speed is only 10 kilometer speed only, it may be, and she fell down. And immediately she was complaining of pain in the shoulder, but she was not at all knowing what is happening. What? She was asking. And she was in a shock. That means there is a jerk or one falling, hitting on the floor. That is a very important thing, not to the right side of the head. That's what happened. Right shoulder injury, same time, right head injury. Happened. It happened like that. So we may miss it. That's why even if there is an injury, we have to do it. And then persistently headache, Glasgow Coma score 15, persistent headache, and all assaults. Somebody hitting on the hand, with the stick, with some other instrument, all those things you need to do the assault. We have to take. So if you see these indications, any injury, you have to take a CT scan. That is very, very important. But only thing is, CT scan is a little bit costly based on the thing. And nowadays, the CT scan is available for less charges, even freely available in the government medical colleges. And they charge less for the paying patients. And even the scan centers are multiple and they are doing for minimal charges they used to collect and they do it. So it is not at all a costly investigation nowadays. Nowadays, people are paying 500 rupees for a cinema ticket. Why can't they pay 500 rupees or 1000 rupees for a CT scan? Because the life and death, we are able to see that. Okay? That is very important thing. Then, in the CT scan brain, what all things you will see? Already our Anbarasa sir has told so many things in detail. Some of the things I used to enlighten up. EDH extradural hematoma, SDH subdural hematoma, SAH subarachnoid hemorrhage, IVH intraventricular hemorrhage and hemorrhagic condition. And then hydrocephalus, that is dilatation of the ventricles can be seen. And cerebral edema, there is obliteration of the basal systems if there is edema in the skull. And cerebral anaxia, loss of gray white interference, and the skull fractures. Elevated fracture, depressed fractures, and underlying hematomas can be seen. Hypotense condition, sometimes always the conditions will be hypertense, but hypotense conditions also can happen. Sometimes there may be a bloodless area can happen that can lead to hypotense conditions. And pneumococcus, black spots, already I was telling, and shift of the midline structures. These are all the things that we will see in a CT scan brain. And when will you do the second CT scan? If there is any deterioration in the level of the consciousness, or 3 to 5 days after the injury. A third CT scan, we can do it only on 10 to 14 days, or whenever often needed when there is deterioration. When we suspect abnormalities, we do it. The CT scan brain, I want to give one example. A 9-year-old male, history of fall from two-wheeler, no history of loss of consciousness, Glasgow coma score is 15. Pupil 2 millimeter equal reacting to light. Abrasion on the right eyebrow, edema upper lip. Will you take CT scan in this case? Most of the people will not take. So we have taken a CT scan. This CT scan is showing a right frontal hematoma, and then this is the left territorial bleed. So what we need is admission in ICU and neuro observation. Another thing is the parietal extradural hematoma. This is the classical. Extradural hematoma is an area of hyperdensity. Already sir was telling about idli. It is like an idli only, and it is a biconvex. Actually, it's called as a biconvex, convex shape, biconvex shape, and then hyperdensity is seen. We take it as a extradural hematoma. If there is some hypodensities inside the hyperdensity, we take it as a active bleeding. Active bleeding is happening in this. And then this is the subdural hematoma. He say concave convex. Concave convex. This takes the shape of the brain actually. In extradural hematoma, it is a space occupying lesion in between the brain and the bone. That's why it takes a classical biconvex shape. But in a case of a subdural hematoma, it takes the shape of the brain because it is in the subdural plate. That's why it is taking a shape of a concave or convex. And then showing the midline structures. Always you draw a line from here to here. That is called midline. If it is shifted, that is the classically a clot which is shifting the brain to the opposite side. And then this is one classical example of a chronic subdural hematoma. There is an area of the left parietal hypodense area, the midline shift. This is a classical left chronic subdural hematoma. And then occipital extradural hematoma. This is an occipital extradural hematoma, which is sick. And this is a very, very important picture. You all have to be, if you want to read a CT scan, you should by heart this picture and keep in your mind. Even you can take a nice photograph and keep it with you because very, very important thing. By the bedside, if you see the biconvex shape, it is an extradural hematoma with midline shift. The concave convex with an acute subdural hematoma with the midline shift. The chronic subdural hematoma is more or less biconvex because this subdural hematoma, which is having because of the injury, which is getting collected close to the bone, which start liquefies and then produces the increase in their volume and presenting like this and producing a gross shift to the opposite side. This is a classical picture of acute SDH, EDH and chronic subdural hematoma. Very interesting finding. The another example I want to give is some mimicking of a stroke. A case of 80-year-old male admitted with the history of weakness of the right upper limb, difficulty in talking. Difficulty in talking. The right upper limb monoparesis. When they have weakness of the right side of the body, most of the dominant hemisphere, left side hemisphere patients will be having a aphasia or difficulty in talking. That is called facio-brachial monoplegia, and it can be a Curie CVA. Plantar also flexor for this case. And this was a classically like this. And it was a chronic subdural hematoma. So it is a mimicker of a stroke. Mimicker of a stroke. Then coming to the MRI. It's important, sir. MRI, sir. In acute phase, it's not appropriate, sir. Because longer acquisition time, it takes time for it to. Patient will be restless and moving the limbs, and even a small movement will change the gadgets in the MRI. That's why it is very difficult. And so nowadays CT scan, people used to take even within 30 seconds, the whole body CT scan they are taking. It is happening like that. And this is a longer acquisition time. And it is less access to the patient because only few centers are having a MRI. And it is a little bit costly compared to the CT scan and less sensitive in detecting the acute blood. The advantages are we can find out the brainstem injury, the white matter changes, the corpus callosal injury, and the diffuse axonal injury. All those things can be made out in MRI scan. This is a case of normal CT scan, abnormal. Right? RTA, injury to the left upper limb. Aphasia, weakness of the right upper limb. Weakness of the right upper limb. So this is the normal CT scan. Brain is normal. This is how the skull bone is normally seen. The ventricles are seen. The brain parenchyma is normally seen. The basal cisterns are seen. Clearly, there is no the gaping inside the skull bone. That's what happened. And MRI, diffusion weighted images. The apparent diffusion coefficient images and dark and white images are to be recorded. And here it is see the dark images, there are areas of hypo intensity seen in the left parietal region. And this is white. They are seen as the hyperintense images. And this is what they present. And this patient is having a weakness on the right side. And this is a left-sided injury is present, which is a normal CT scan, abnormal MRI. And then this is a patient K, who is presenting with a laceration over the left frontal. His Glasgow coma score is 13/15. And his CT scan, see here, there is a hyperdensity seen in the right frontal region. There is a left laceration, right side clot. This is a Coop injury, contra Coop injury. Coop injury means only laceration was there, but Coop is, if there is a pathology here also, then we will call it as Coop injury. Otherwise, here, there is an injury here, subsequently producing a clot in the opposite side. Okay. See, this is the patient, laceration, opposite side clot, subdural hematoma. Coop and contra Coop. What is Coop and what is contra Coop injury? That's what. See here in this CT scan. Here, there is a fracture with an extradural hematoma on the right side. And on the opposite side, diagonally opposite side, there is a hyperdensity is seen, which is the hemorrhagic condition in the left temporal lobe. And then there is a thin acute subdural hematoma. There is a thin acute subdural hematoma with the left temporal hemorrhagic condition, which is also seen in the sagittal views. And there is an extradural hematoma on the right side. This is the Coop injury. This is contra Coop injury. That is because when the brain is going and hitching on the skull bone, it produces like that. Okay. See here, the same thing. See here, the nice fractures are seen on the right side and left side, the temporal condition and temporal SDH. This is the Coop and contra Coop injury. In the same picture, I am showing all these things. Coop and contra Coop injury. Then coming to the impending foreign body, skull. In the skull, the patient reporting to the OP with a protruding foreign body, which is seen on the left side. Foreign body with a part inside the skull cavity, other part protruding outside. So what you will do immediately? Immediately people used to think about whatever is protruding, pull out. That's what the routinely our intention or intensity. And also there is bleeding. What to do? So immediately you should not remove it. That is the very important thing. And it is a non-missile knife, lawn darts, arrows, window supports, like that. The protruding part of the object is removed only in the operation theater after craniotomy. They open the dura before removing the object after exposure. And debride the wound, adequate antibiotic coverage, visible evidence of arterial bleeding, we have to arrest. That is very, very important. Surgery goals, debridement of the devascularized tissue, evacuation of the hematoma, removal. It is a bullet injury or gunshot injury where the bullet may be crossing the midline, bullet traversing the ventricle, more lobes traversed by bullet, suicidal attack are more fatal. For example, recently we had a skull injury by our DIG Vijay Kumar, who just got the gun and he triggered on his head, immediately died, fell on the floor. That's what happened. That will happen in the gunshot injuries. Always, they will not, most of the people will not reach the hospital. But when they target from a longer distance, if they put the bullet, sometime when it is hitting on the skull, there may be different type of injury can happen. Okay, so that is a very important thing. So in a management of head injury, how to manage head injury with polytrauma or without polytrauma? Without any injury, only pure head injury matram da irukku appdi solluvaanga. So in that case, what you do is minor head injury, 9 or more GCS, 8 or less. If it is 9 or more, just observe, do your CT scan. If it is positive, admit, negative, discharge. Major injuries, endotracheal intubation, ventilation. Then do CT scan and then surgery and medical treatment. That is the plan. This is one shot. Here is a polytrauma. Stable signs. Go back to here and assess like this and do it. Unstable vital signs. Stabilize, diagnostic procedures, emergency treatment, and then stabilize the vital signs. Then treat the head injury part. That's what. So stabilization is very, very important thing in any injury. And then subsequently look for the head injury. So head injury, sir, head injury patients have come, sir, in my clinic, sir. When to refer to the neurosurgeon? Whether all patients are to be seen. Patient with a Glasgow coma score less than 15 after correction of hypovolemia or hypoxemia, simple fracture with epilepsy or focal deficit, compound depressed fracture, CSF leakage, persistent progressive headache, neurological symptoms and signs, we have to take the neurosurgery opinion. That is very, very important. And then what are indications for admission? History of confusion, loss of consciousness or amnesia following head injury. Patient with a skull fracture, ear bleeding, nose bleeding. Patient with neurological signs and symptoms. Difficulty in assessing the patient. Patient is alcoholic, had an epilepsy and in unconscious. Other medical conditions, we need to do admission to the patients. So medical treatment, head and elevation, 30 to 45 degree elevation, mannitol, hyperventilation, steroid, antibiotic, anticonvulsant. These are all the medical treatment which are all available routinely for any head injury. One by one we will come. The management, mild to moderate head injury, bed rest, head elevation 30 to 40 degrees, neuro observation, pupil, heart rate, respiratory rate, BP, consciousness, nil per oral until oral, and fluid replacement. If they are not alert, we can start with the resistive feeding. My fluid replacement, isotonic fluid, normal saline is the best fluid to be given, 100 cc per hour, that is the best. And mild analgesics, acetaminophen or diclofenac, antiemetic, ondansetron, avoid phenothiazine derivatives. Patients fail to reach Glasgow coma score in 12 hours. Repeat the CT scan brain. This is one important thing which I wanted to tell in management of an head injury. This is what called Huawei head washing tray. Head washing tray is an important tool in neuro department in all hospitals. I don't know how many of you have seen this. It's a very, very important tool. It should be there in all hospitals to give care for the head injury patients. See, this is the head washing tray. See, this is like a shape of a Lincoln Audi. It is like this. And then you keep the head like this and neck here, and you can do a nice washing before doing the suturing or before giving care of the patient. See here how we are doing. We are keeping the tray like this, and the saline is coming, the water is coming and falling on the tray like this. This is very, very nice thing. Head washing tray is an important tool in neuro department in all hospitals. Very, very important thing. The Huawei head washing tray, which is, see the water, the sister is pouring and it is coming down onto the buckets after the shampoo wash. See here, a nice wash is given. So this is an essential tool in all hospitals. For getting, contact this number, the 9894-337-111 and 936-003-0094. This is my number. You can call me, I can guide to that person. Then regarding the mannitol. So mannitol, when it is indicated, sir, raised intracranial pressure, focal deficit, sudden deterioration before CT scan. Before CT scan, if there is deterioration of the patient, only you can give. Otherwise, you should not give, because sometimes if there is an extradural hematoma, there is every chance for it to worsen. So the contraindications are extradural hematoma, hypotension, and coagulopathies. You should not give mannitol. Dose is bolus 1 gram per kilogram body weight over 20 minutes. The anti-epileptic drugs are phenytoin load 17 milligram to 20 milligram per kilogram body weight slow IV, Follow 100 milligram slow IV 8 hourly. Coming to the anti-epileptic drugs, what we are using are, this is the phenytoin is the olden days drug, which is even now also people are using it. Now so many drugs have come. The easiest drugs which we are now people are using is, one is this levetiracetam. Levetiracetam is a one drug which is not having much of the complications, and that can be given 10 to 15 milligram per kilogram body weight is the dose. BD dose has to be given in a diluted manner in an unamble saline. Slow infusion has to be given. But phenytoin in olden days itself, our teaching also, our professors also used to teach. When the person is having continuous convulsions, they used to give it, dilute and give it. They will put it in a saline bottle and slowly give it. It should not be like that. Even now also, you take a phenytoin ampule and read what is written on the phenytoin ampule. It should not be diluted and given. That is the instruction that is written on the bottle. So, people who are using phenytoin never use it in a diluted form. But levetiracetam is the drug which you used to use it with dilution. Then intubation and hyperventilation. When there is decrease in the level of consciousness, Glasgow coma score less than 7, cerebral edema not responding to mannitol, severe maxillofacial injuries, inadequate respiratory, avoid mesotracheal intubation. That's what already I was telling. Mesotracheal intubation, there is a chance to go into the skull. So how is the role of the anticonvulsant in head injury? This indicated. History of seizures in the site of the injury, intracranial slots, cranial foreign body, positive findings in the CT scan brain. How long to continue? Anticonvulsants are used minimum period of 18 months or till EEG becomes negative. Even we have seen patients who are having EEG negative and stop the drug after 2 years, 3 years, 5 years. We have seen patients presenting with convulsions. So always you put them on a small minor dose. That will be better instead of getting a convulsion and facing the trouble. Because nowadays, even if you say the male persons not to drive the two-wheeler or females also not to drive two-wheeler, they will take the two-wheeler and drive. There is every chance for them to get into an accident and fall. So it is better continue the anticonvulsant and not to stop it. And then some facts about the epilepsy you should know. Epilepsy is caused by a real cause. We should have 2 attacks of seizures always. Best drug in pregnancy is phenytoin, is the routine drug. But nowadays we can try with lamotrigine, 12.5 milligram per day. The maximum up to 100 to 200 milligram per day can be given. The another drug which can be tried is levetiracetam. So the drugs which are available are phenytoin, lamotrigine, and levetiracetam. You avoid sodium valproate. And then regarding role of steroids, whether steroids can be given or not, steroids are not having much role in any of the cranial problems. Only when there is suspected optic nerve injury or oculomotor nerve injury or sometimes facial injury, you can give. Not routinely used in cerebral edema. Previous days, our lesson, you whatever it is, you give steroid. Not like that. In my experience, from the day when I started practicing till now also, even in neurosurgical practice also, now I am having 23 years experience in neurosurgical practice. And in that, we are not at all using any steroids. Very, very important thing. So steroids are not having much role. And even the spinal cord injury also, we are not at all using this steroid. That is a lesson. We should try to avoid these steroids. Very important. Sedation, not at all given in head injury. Sir, patient on the kaiya kaal aadittu sir. Sedation kudutha, you cannot assess the patient. There is chances for aspiration, chances for pneumonia and going for ventilation. A small point about the severe head injuries. Indications for ICP monitoring. All cases of head injuries who are having a Glasgow coma score, ICP is intracranial pressure monitoring. Glasgow coma score less than 8. Multiple conditions with conservative management. When they are having multiple conditions, we are putting them on conservative management. You try to avoid the, you have to do the ICP monitoring. Large non-operative clots, post-operative hematomas on ventilator, mass lesions post-operatively on ventilations. We can do the ICP monitor, intracranial pressure monitoring. The ICP monitor is the monitor. Nowadays, it is more advanced. See, there will be a burr hole will be placed and a small transducer will be kept inside the cerebral cavity. Cerebral cavity, a small transducer will be kept inside the cerebral surface, and then we will be having a monitor like this, which will be showing the intracranial pressure. That is the thing. So, in raised intracranial pressure should be maintained below 25 millimeters of mercury. Ideal is 15 millimeters of mercury. The cerebral perfusion pressure should be more than 65 millimeters of mercury. The cerebral perfusion pressure is the mean arterial pressure minus the intracranial pressure. If the cerebral pressure ICP is raised, then we have to give the raise the head end of the bed, evacuate the hematoma, access the contusion, and drain the CS. These are all the things. Then a small few points about craniotomy. Craniotomy is the opening made in the skull bone after making an adequate burr hole and to remove the large area of the bone which can be replaced back if needed. Craniectomy is the process in which, with the help of the single burr hole, the bone defect is widened to make it as a big defect. Removed pieces of the bone cannot be replaced. That is the craniectomy. Burr hole is the small hole made in the skull bone with the help of the specialized instrument called a Hudson's brace or the craniotome. The craniotomy instrument, these are all the instruments that are used. The 22 size blade knife, side curved artery forceps, monopolar cautery, bipolar cautery, Hudson's periosteo elevator, Hudson's brace, perforator or craniotomy, motorized, burr, and giggly saw, giggly guide, bone wax, 30 silk with needle, dural hook, 15 size knife blade, a knife, 20 vicryl, 10 ethylene, 12F size Ramovac drill. And how the craniotomy is done. We make a skin incision, scalp flap is reflected, muscles reflected at the site of the burr hole. Burr holes are placed with Hudson's brace, perforator, and burr by the craniotomy with a giggly guide and saw, or with the cutter we used to cut. Electronic cutters are available nowadays. Bone flap turned, dural hitch applied all around, dura cartridge and open, dural flap turned, planned procedure done, dura closed with continuous sutures, bone flap replaced, tube drain kept, wound closed in layers. For the craniotomy wounds, what type of a drain to use? You might have seen the drain which are kept for the abdomen. You might have seen the drain which are kept for the fractures and long bones and all those things, limb injuries. Here we used to use these small drains which used to give. We can use the 8FG drain or 9FG drain. That is of much use. We cannot go more than that. And then regarding the skull fractures, the depressed fracture elevation criteria, more than 8 to 10 millimeter depression. We have to do compound open depressed fracture. We need to elevate and excise. And open the comminuted fracture, excise the depressed bone, elevate the depressed fracture, close the dural defects watertight, laceration of the dural venous sinus, prepare for blood transfusion, small Fogarty catheter to occlude the sinus, prepare saphenous vein area, bone fragment lacerating sinus, remove last. The basal skull fractures, most are treated conservatively. The surgery indications are traumatic aneurysms, post-traumatic carotid cavernous fistula, CS of rhinorrhea, cerebral abscess, cosmetic deformity, post-traumatic facial palsy. Extradural hematoma, clinical feature, brief loss of consciousness, lucid interval, contralateral hemiparesis, ipsilateral dilated pupil. If not treated, they will go for decerebration, hypertension, respiratory distress, and death. So high density biconvex lesion adjacent to skull bone is extradural hematoma. Small extradural, no symptoms or signs. Treat, admit, observe, follow up the CT scan. Yeah, EDH surgery indications are symptomatic extradural hematoma, asymptomatic hematoma, more than 1 centimeter thick part, EDH in pediatrics. You do evacuation of the clot. This is an example of an extradural clot which is seen like this, where the objectives are clot removal, then bleeding vessel is arrested, bone wax used to deploy bleeding, prevent reaccumulation, dural hitch, if possible, replace the bone wax. EDH surgery indication, symptomatic EDH, already I have told. And this is one patient example, was driving a two-wheeler and was hit by a horse on the scooter, and it climbed on him and crashed him. This is what happened. And it was presenting with a hypertensity in the deep brain, and it was the shift is there. So this patient had a decompressive craniotomy on that side and operated and recovered well. This acute subdural hematoma. The acute subdural hematoma, blood collection on the parenchymal laceration, tearing the surface of bridging variations, presenting mass of hypertensity adjacent to the inner table with a midline shift. The rapid surgical decompression, SDH evacuation, more than 1 centimeter thickest part, 0.5 centimeter in pediatrics, large craniotomy flap to evacuate thick clot to gain access to the bleeding sites. The bone flap is replaced or removed based on the edema. This is on pictures of SDH evacuation, which has been done. Here the skull bone is seen, the bone is removed in this part, and the dura is intact, and the dura is bluish in color. After opening the dura, the subdural clot is seen, the cerebral hemisphere is seen. You see the cerebral hemisphere. That's what. Okay, after evacuation. And the traumatic brain injury, the secondary insult, we should be thinking in terms of hypotension, hypoxemia, hypercarbia. This penetrating wound already I have told, and penetrating the bullet injury also I have told. The bullet injury, the gunshot wound, majority of penetrating injury, gunshot. Most lethal head injury, 2/3 die at the scene. We examine the entrance wound, which is smaller than the exit wound. That is the classical of a entry and exit wound. General measures are CPR, fluid replacement, AP and lateral skull X-ray, non-contrast CT scan, bullet track into dural hematoma, and parenchymal location of the bone and metal. The angiograph, unexpected hemorrhages, trajectory pass, named vessel, we have to operate. Then another thing is one as a care of the head injury patient. Often we miss some of the things and we land in trouble. See, this patient is having head injury and operated. This is a craniotomy done. And you see, there is the corneal opacity happened for him because of the eye is not closed well. See, eye is not closed to corneal opacity. See, now the eye actually has to be closed like this. You should not put a plaster like this. You should put a plaster from the lateral end to the lateral surface of the eye. That's how you should do. You should not put it like this. And then nutrition in head injury patients, adequate fluid replacement, IV fluid, right tube feeding as early as possible, non-paralyzed patients, 140% of the basal energy expenditure we have to give. The protein, the provide more than 15% calories as protein. This is one patient with 35 years, injured while traveling a van, co-passengers also injured, history of loss of consciousness present, bleeding from the scalp wound present. Emergency department, unconscious, inadequate respiratory effect, bleeding from the scalp wound, active resuscitation was done. You see, he was having a convulsion at the time immediately, and see how much blood is lost from the wound. That's what happened. So airway, endotracheal intubation, breathing, ventilatory support, circulation, control of the bleeding, subclavian catheterization, control of the convulsions. That's what we need to do in this particular patient. See how much artery forceps and all those things applied. There was a massive bleeding around. That's what happened. His CT scan brain was showing left temporoparietal intracerebral hematoma, basal cisterns not seen, compression of the ventricles were seen. And at the time of discharge, this is a team effort. the CMO, anesthesiologist, and neurosurgeons, they treated, and he was having a right side ptosis. Left side he is able to blink well, and that's what happened. And he got discharged gradually, even with that type of an injury. And there was having a mild weakness on the right side, upper limb and lower limb. That is what happening. Okay. So head injury, helmet. Nowadays in Coimbatore, already they have told that the rider and pillion rider has to wear the vehicle to helmet. The crash helmet's very important. The helmet protects our brain like a mother protecting a child in her uterus. So helmet is very, very important. And wear seat belt. Prevention is better than cure. Wear helmet, wear seat belt. Thank you.
Rajesh Babu sir.
Yeah, thank you, sir.
Thank you, sir.
Devanand sir, you can.
Yeah, Rajesh Babu sir, it was a really fantastic lecture, and you and Dr. Anbas they have covered the whole topic of head injury. And it was really exhaustive. Rajesh Babu started from the way the patient should be managed, the patient, how the care should be primary care, the imaging, and what are the drugs to be given, and post-procedure care, and also the video that you showed of the real acute emergency as a teamwork, how the patient's head injury has to be managed is really very excellent one, sir. And regarding the doubts that raised, one doubt that was raised in the chat box was, is there any role of blood, what to do with the blood thinners? Suppose the patient may be having an aspirin or any blood thinners for the cardiac conditions. What to do for the head injury patients, whether they can give the blood thinners?
Dr. Rajesh Babu. Dr. Rajesh Babu, could you hear?
Rajesh Babu, sir? I think. And there is one more question. Sir, some people, some participants, they're asking about the slides to be shared in the group or something, sir.
Most of these cases examples are available in the net already. If you type, in the Google head injuries slides, there is a lot of slide share images, and a lot of images are available on head injury. Multiple images are available. In fact, if you type extradural hematoma, you will see 50 different examples. So I think it's very easy for people to see. Diffuse axonal injury also, there will be some cases.
Okay, sir.
And
Rajesh Babu, sir, it's not. Sir, and then one question which was asked related to credit hours. So actually, some people, they were asking whether after the stipulated time there will be any revalidation possible or not. So actually, it depends upon how the NMC draft becomes gazette, and according to that, they will take necessary steps. But it is always better to accumulate more credit hours so that it becomes easy for us in future, and we don't have troubles, and our practice goes very smoothly. Recently, in I think in Karnataka Medical Council and Mumbai, Maharashtra Medical Council, they have not renewed the e-registration. So it is always safe to get the required credit hours and be in the safe zone. And also, we'd like to announce that tomorrow's session will be on model consent forms in medico-legal aspect. So our PPLSS legal advisor, Dr. Tangamuthu sir, is going to have an extensive session. And there are 5 moderators, each from surgery, ortho, gynec, sonology, radiology, everything. So we will be sharing the consent forms in the groups or state official CGP groups. So the model consent form, after discussion with the experts, it will be shared. So I request all of you to attend the session tomorrow. And also all the sessions has to be attended to get the full 5 credit hours. So the credit hours, it is for whole conference, not for individual day. Yeah. And I think Devanand sir, you had a very good session today.
Sandil, Rajesh
Yes,
Babu
sir.
sir just called me and said to unmute him. Apparently, he's got muted. He couldn't
Just a
speak.
minute, sir. Rajesh Babu sir,
He
unmute.
couldn't answer the question.
Unmute. Rajesh.
Meanwhile, I have a question.
Yes, Dr. Devanand.
Yeah. Is there any indication for other modalities other than a CT scan in a head injury? You have given a lot of slides.
Yes. See, the CT scan is the primary imaging modality where it will help us to manage the patient in the initial stages. But when there is a discrepancy that the clinical presentations and CT manifestations are not matching, then we have to suspect, as I already informed the audience, that the diffuse axonal injury is one particular condition where there is additional findings are seen on MRI scan. But that should be done after stabilization of the patient, because going into MRI scan with all the sort of metals and ventilations can be very, very difficult. So you have to, patient should be in a manual ventilation. You have to use compatible MRI compatible instruments should be there. So that has to be planned and discussed with the MRI team and before the patient is shifted from ICU to the MRI. So that needs to be carefully done. I think Rajesh Babu sir is back. I think.
Rajesh Babu sir, there are some questions for you, I think.
Rajesh Babu sir, there is one question regarding the role of blood thinners in a head injury patient. About the blood thinners, a patient may be having blood thinners for a cardiac condition. What can they do for the patient, this type of patients, whether they can continue the blood thinners, what to do the blood thinners?
Sir, if they have the blood thinners in the head injury part, it is better to stop it for the time being. That is the main thing. And sometimes if really indicated, we can continue. If there is a subarachnoid hemorrhage like that, you can continue. But not in the subdural hematoma or extradural hematoma is present. We need not give. If there is a subarachnoid hemorrhage is there, or a small cortical conditions are there, we can only give the blood thinners.
That's good, sir. Thank you. That's really useful information.
Yes,
it was audible, sir. Then I think suddenly it was muted. And now we have removed you as a co-host. Oh, fine, sir. Okay. Okay, sir. Sir, and really it was very good extensive session, sir. Oh, fine, sir. Sir, what's the treatment for diffuse axonal injury? So there is one question. What's the treatment for diffuse axonal injury?
Rajesh Babu sir, can you hear us?
I think he is having some problems.
So diffuse axonal injury only supportive therapy only, sir. The patient is able to breathe well and sir, it is echoing because you are having two instruments, I think.
Yeah.
One, you have to mute it.
Yes, sir. Now it's fine, sir.
Hello?
Yes, sir. Now you can talk, sir.
Hello?
Sir, what is the treatment for diffuse axonal injury? And there is one more question. I think, sir, that's the question, sir. Yes, sir.
So for diffuse axonal injury, when the patient is presenting with diffuse axonal injury, if the patient is unconscious and is not having adequate respiratory efforts, we need to ventilate the patient and we have to give the supportive therapies like if the edema is there, anti-edema measures the mental and anticonvulsant routinely used to be given, and cerebral protective drugs we can give. Cerebral protective drugs which are available now are the citicoline is available. Then the pyracetam is available, like that. Like drugs can be started to give the supportive therapy, and day by day, once they show improvement, we will wean off from ventilator. That is the thing, and nothing else we can do. But gradually, the neurons slowly improve, and if they are less than 50 years, the chances of recovery is very good. They are more than 50 years, it is very difficult for them to come around. That is the thing.
Thank you, sir. And one more thing is, what are the available MRI compatible implants?
So MRI compatible implants are our titanium implants are MRI compatible. Titanium implants, that's what they are using now in the aneurysm clips, all those things, and then the silver clips also, which they are doing for the these AV malformations. With that also available in titanium. The titanium clips are the main thing, which are mostly MRI compatible, sir.
Okay, sir. Fine, sir. Sir, Sengutun, sir.
Yes, I
you
am
have
here.
any? Yes, sir. Sir, any questions from your side, sir?
No, regarding the head injuries, Rajesh Babu, nowadays,
yes, sir.
levetiracetam is often used in pediatric cases. We are using the levetiracetam. Is it in the adult also? It is commonly used.
Yes, sir. We are using that only, sir, because of all the complications of the previous drugs. For example, if you use phenytoin, sometimes there may be a lot of complications as drug allergy and anaphylaxis and all those things are happening now, sir. That's why we are now on arrhythmia, all those things are coming. That's why nowadays we are not using the phenytoin drug at all. The second line people used to use is the sodium valproate. They used to use it, sir. That is also that is having a complications of liver failure. And another thing which is phosphenedione, people used to use it, sir. But when you see the phosphenedione label, they used to tell that it has to be kept in the cold storage, which is not at all possible. But people are still using the drugs, sir, because in the phosphenedione, the cold storage is not at all being continuously used. That is why the drug which is commonly used nowadays is the levetiracetam. And then nowadays people are started using the breveracetam also available. And another thing is lacosamide is available. And then the lamotrigine is available. These are all the 4 drugs that can be tried nowadays, sir.
Okay, sir. Yes, sir. You have given a very nice lecture, starting from the basic to high end.
Thank you, sir.
Hats off you, sir.
Thank you, sir.
Sir, there is one question related. Any specific protocol for head injury in children and the pregnant ladies?
Sir, the protocol is similar to what I put in the label.
Right, sir. Fine, sir.
What is the management of the head injury is same for both the things, sir. But only thing is frequently monitoring the level of the consciousness if they are conscious, which is going for the drowsiness and all those things. And another thing is regarding the pregnancy, CT scan we can take once for pediatric. It is not of a big abnormality, sir. But for the pregnant people, when we are taking a CT scan, there is chance for exposure, and we cover with a lead apron and do it. But if we see a patient with the MRI straight away, rather than doing for the CT scan, we can suggest a MRI scan instead of CT scan if we suspect pregnancy, that too in early stages. And then the rest of the treatment management will continue the same, sir. Recently, we had one patient who had a abdominal injury, it is head injury, and who was carrying a child, and she was treated conservatively, and she went on well without any complications. And that's why I have put on slide, which was showing about the role of anti-epileptic drugs. That's what for the thinking in terms of pregnancy only, we can use boldly the phenytoin, we can boldly use the levetiracetam, we can use boldly the lamotrigine, but not the sodium valproate. That's what I was telling. The rest of the things, same supportive, and based on the level, we have to do, if there is a big clot, we need to operate. Small clot, observe, treat conservatively. That is the plan, sir.
Oh, thank you, sir. Very nice, sir. Sir, any other remarks, sir? Anwar, sir, anything you want to add, sir?
Sir, one person has mentioned that the dilution of about the phenytoin. Phenytoin, that's what I always was telling. People are using it. The olden age people, our lesson was to give dilute and give it. Because in the normal saline bottle ஒரு 10 ml போட்டு கொடுங்க அப்படின்னு சொல்லிடுவாங்க அந்த காலத்துல. அதே தான் ஃபாலோ பண்ணிருக்காங்க. But even now also people are doing it. So we should not do it. நீங்க வந்து அந்த ஆம்பிள் எடுத்து படிச்சு பாருங்க. இன்னைக்கு போய் எல்லாரும் எடுத்து படிச்சு பாருங்க. Phenytoin ampoule என்ன எழுதிருக்குன்னு படிச்சு பாருங்க தெரியும். Phenytoin ampoule வந்து எழுதிருக்கும். It should not be given diluted and given அப்படின்னு எழுதிருக்கும். அதுதான் பாயிண்ட். அதனாலதான் டைல்யூஷன் கொடுக்கவே கூடாது. எவ்வளவுமே அதனால டைரக்டா நம்ம கொடுக்கும்போது சம்டைம்ஸ் சடன்லி they may go for arrhythmia and the complications. That's the main thing. We are not at all using the drug nowadays. Why already in head injury, why you go for one more complication? To prevent that only we are not using, nothing else.
I think we have today covered the entire gamut of head injury, not only from clinical presentations, but also through the diagnosis using CT and the additional use of MR, plus excellent management options and discussion by Dr. Rajesh Babu. It was a very comprehensive coverage of all head injury and also the risks involved in managing in these patients and also the medical legal aspects. Where are all the pitfalls can happen. I think overall it was a very good session, and thank you very much, Dr. Rajesh Babu and Dr. Devanand, our chairperson. If it is okay, hand over to our.
Thank you, sir. நீங்க கூட about the head injury, நீங்க வந்து முதல்ல நானே பேச வேண்டியது நினைச்சிட்டு இருந்தேன். நீங்க பேச ஆரம்பிச்சதுன்னா நான் பேச வேண்டியது இல்லை போல இருக்கு. சாரே வந்து எப்ப ஆபரேட் பண்ணு சொல்லி
சார் எப்ப ஆபரேட் பண்ணதா சொல்ல முடியும், பட் ஆபரேஷன் நீங்க தானே சார் பண்ண முடியும்.
சார் இஸ் கிளினிக்கல் ரேடியாலஜிஸ்ட்.
இல்ல அவரே எக்ஸலென்ட்டா சொன்னாரு. எடுத்த உடனே ரொம்ப நல்லா சொன்னாரு. ரொம்ப நல்லா இருந்தது.
வெரி நைஸ் சார்.
Thank you, sir. Sir, Secretary sir, can you just give a concluding remarks and also give a formal vote of thanks, sir?
Right. Thank you all. Regarding this today's program, almost all of them have cleared their doubts regarding the TNMC credit hours. Sendil has explained everything in detail, how to accumulate and what would be the future guidelines by the NMC. So adequately store your credit hours in all aspects. Attend all the seminars, live online meetings and conferences. Regarding the Dr. Anbarasu, he has elaborately explained about the radio diagnostic procedures, and Rajesh Babu also explained everything in details. Thanks to all the speakers on behalf of the IMA Tamil Nadu CGP chapter. Thank you one and all. Hello.
Yeah, yes, sir. Thank you, sir. Yes, sir. Thank you, sir. Sir, audible, sir?
Yes, you are audible.
Yes, sir. Fine, sir. Thank you so much, sir. And again, I thank our speakers and our moderators. Anwar sir readily accepted, and also Rajesh Babu sir done extensive session, sir. Thank you so much, sir. And hope we can do a session on BLTS in future, as you are a very certified instructor and a senior person in this. Thank you, sir.
Thank you.
Yes, sir. I think we can end the session, sir. And the session will be The chat box will be open for a few more minutes. Anyone not entered the attendance, kindly enter the attendance. And also kindly attend all 5 days or next 4 days also, so that you can get a full 5 credit hours. So it is an all or none phenomenon where you can get either 5 or 0. That's all. Thank you, sir. Thank you.
Thank you.
Thank you,
We'll
sir.
meet
Thank you,
tomorrow.
sir.
Thank you, Dr. Sendil, and all the
Thank you,
CGPA team and the President, Dr. Sengutun, sir, and the State National President. That's a fantastic effort. Congratulations.
Thank you,
Thank
sir.
you. Thank you, sir.
Thank you, sir.
Thank you, sir.
Yes, sir.
Shall we conclude, Sendil?
ஹலோ, எனக்கு முன்னாடி கொஞ்சம் தெரியணும் எவ்வளோன்னு. எனக்கு பட் டக்குனு ஈபிக்கு நான் 1,00,000 நான் இப்போ கூட 70,000 கரண்ட் பில் கட்டு. அதனால எனக்கு வந்து டாக்டர்ஸ் நீங்க கொடுத்தேன்னா அப்பப்போ
இந்த மாதிரி எடுத்து கொடுத்தது கூட சனிக்கிழமை வாங்கிக்கிறாங்க.
பணம் வேணும்ல கட்டணு. இருக்க அப்படின்னு தெரிஞ்சாதான் நான் இருக்கு. இதெல்லாம் பேங்க் கட்ட சொல்லி இருக்கிறேன். ₹2,00,000.
36 ரூபாய் கட்ட சொன்னீங்க. நீங்க 6 இந்த அமௌண்ட் ₹2,000 நோட் கொடுத்தேன்.
ஆமாண்ணா. இல்லடா. ₹33,500